Hello. What I'm going to ask is, I know most of you are here for the third bill. We have people for the first and the second bill out there. If you could make your way out so that the first and the second bill people can come in so we can hear their testimony. And we'll call you back in when the third bill's ready. Thank you. Okay, can we welcome to Health and Human Services? Could we stand for the pledge? And Senator Rosenwald, would you lead us in the pledge?
Oh, thank you. I pledge allegiance to the flag
of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All right,
Madam Chair.
you're welcome. And we will start the hearing on Senate Bill 32 relative to the Opioid Abatement Trust Fund, and the prime sponsor, Senator Rosenwald. Welcome.
Thank you. Thank you, Madam Chair. For the record, I'm Senator Cindy Rosenwald from Senate District 13 in Nashua. And as chair of the Opioid Abatement Advisory Commission, I'm pleased to introduce Senate Bill 32, which makes changes to the operation of the Opioid Abatement Fund originally created in 2020 to manage the settlement funds for opioid litigation that are coming into the state and will 18 years or so. Of these funds, 15% go out immediately to 23 litigating subdivisions, and the balance goes into the fund to be granted by this commission. There are 22 members on the commission representing subject matter experts, HHS, Corrections, Department of Justice, the Governor's Commission on Alcohol and Other Drugs, nonprofits, and local government entities. We held our first round of grant applications this fall for $6.6 million. The contracts for the awards will go before the Executive Council next month. That's the plan. Since that time, more money has come into the fund, and I anticipate that we'll schedule another round of grant applications this spring. This bill comes out of our experience in soliciting and awarding funds over the past year, and it does really three things. First, it establishes a requirement that we give out grants at least once a year when there is at least $5 million in the fund. And I should note that there will always be at least $5 million in the fund for about the next 18 years because of the way some of the settlements are structured. Some are lump sum all at once, and some are paid out over a period of 18 years. But there's currently no statutory language about how often we give out the funds and how much money we have to give out. So this bill does that. Secondly, the bill clarifies and makes a couple of additions to the eligibility categories for grants. These are recommendations from the subject matter experts. And finally, it updates the statutory language to reflect best practices in the field, and it also fixes a couple of typos in the underlying statute that Jenny Gallagher caught this year, 3 years after initial enactment. I'd be happy to answer questions, but also the Department of Justice and HHS have people here who probably can better answer specific questions. Thank you, Madam Chair.
Any questions from the committee? Okay. Senator, I just have one question, and let me know if HHS is better in body to answer this. On line 28, you have lined out states, subdivisions, community health centers, and not-for-profit. Have they been in there before? And why are they being taken out?
I think that the Department of Justice might be
Okay.
better able to answer that question, or HHS.
Okay. All right. Any other questions? Seeing none? Thank you, Senator.
Thank you.
James Buffett? Welcome.
Thank you, Senator. Good morning. My name is James Buffetti. I am the Deputy Attorney General. I've been overseeing the state's opioid litigation since 2015. So we're generally in support of the bill. It makes some necessary corrections and allows the commission to go forward and do what it needs to do and to get these funds out as quickly as possible. If it's of any interest, I prepared a chart that shows the amount of money so far that has gone out to the subdivisions who are qualifying under the statute. It's $6.6 million. I'm happy to provide a copy.
That'd be great.
And also, there is a breakdown of the amounts that we've already received and the amounts that we anticipate receiving through the various settlements.
Okay.
So this gets a little complicated because there are individual settlements with individual defendants. And that has resulted in this sort of periodic payments on different schedules for different resolutions. As the senator said, in some cases, we've received lump sum amounts. So, for instance, we resolved our case with Johnson & Johnson over their opioid practices, and we received $31 million in a lump sum, which was a great result for the state. We entered a multi-state settlement with the three major distributors, McKesson, Cardinal Health, and AmerisourceBergen, and that settlement is approximately $115 million, but over 18 years. And then there were other various settlements. If you may have seen that we've announced in the last month or so a number of significant settlements with the major pharmacy chains, CVS, Walgreens, Walmart. CVS is going to will be paying the state $27 million over 10 years, Walgreens $29 million over 15 years, and Walmart $15 million, which will all come in this year. And then there are other settlements with two other manufacturers that will bring in about $32 million. So it gives you a sense that this money is going to come in at different times, and that the commission's goal is to try and get that money out as quickly as possible to the communities and to the nonprofit organizations that are doing opioid abatement work, so that we can have the greatest effect as quickly as possible. All of the money has to be used for opioid abatement purposes. So it's a dedicated fund that is set up by state law. But in addition, the settlements themselves require that the money be used for opioid abatement purposes. And that's a good thing, but it does provide some limits as to what we can do with the money. So that's, I guess, a long way of giving you some background, but to say that we've been working hard at the commission. I'm a member of the commission. I represent the Attorney General. Senator Rosenwald has provided excellent leadership to us in getting this process going. We have more money to give out. We want to be able to expedite that process. We've worked closely with HHS. They've been such a strong partner with us, and we expect that we will continue to try and get this money out as quickly as we can to New Hampshire communities to abate the opioid crisis, which, as we all know, is still raging in this state.
Thank you, Senator Birdsall. So good morning and thank you
Good
for
morning.
coming. I think I might have answered I'm just going to ask in case I missed something, but
Yep.
right up front on line 6, talking about qualifying projects and, everything is for opioid abatement purposes. So can you give an example? What would these qualifying projects
So
be? And I see as I read
Yep.
through, there's some descriptions
Yep.
that have to say what do with housing, mobile interventions. I mean,
Yes.
is that
yes.
okay?
So it's again, opioid abatement in a broad term, but so treatment, transportation to treatment, transitional housing for people coming out of treatment, the reimbursement of medication-assisted treatment drugs that are given out in our jails and in our prisons. MAT, whatever it is the most effective way of dealing with an opioid addiction. Most of our first responders carry on them naloxone,
Yeah.
which is a reversal drug. So having a way to reimburse communities who pay for their police, fire, EMTs to have naloxone, this would be a way that you could do that, because that saves lives. I mean, so anything that is related to the abatement of the crisis in the broadest terms. We have a doorways program in the state, and we want to continue to provide quick access to people who need treatment and need MAT, and we need to make sure we provide it all over the state, so that sometimes the needs in the North Country are greater than the needs in other places, but there's a variety of needs, and we need to try and address all that to make sure this $311 million that we're going to eventually get is spent as wisely as possible to have the greatest effect on the opioid crisis.
Quick follow-up. Thank you. That was very helpful. So if I'm a not-for-profit, do I work through the communities, the subdivisions?
Nope, you can come directly to the commission. So we opened up a grant, there's a grant application. We've already done one segment of those, one tranche of funds in the process of being awarded. And so you have to be a nonprofit, you have to be registered with the Attorney General's Charitable Trust Unit and be in good standing with the AG's trust unit. And then you can apply directly for the funds. And in fact, that's happening. You can also work with your local city or town or county if you want to as well and partner with them. But you don't have to. You can come directly to the commission and apply for grant funding directly.
Okay. Thank you.
So following up with my question from Senator Rosenwald, on line 28, you talked about the nonprofits were able to bring it in, but they have lined out states, subdivisions, community health centers, or not-for-profit, and replaced it with the state and any political subdivision.
So I gotta be frank, I don't know the reason why that was included. I don't see why that should be taken out. I didn't draft it. So I don't know if there was a reason for it.
I'll ask HHS when they come up.
Yeah, and they may not know either, but because I think it came from the members of the commission. But speaking for myself and from the Department of Justice, I don't see any reason why we would want to exclude not-for-profits, since they're part of this mix
Right.
as well.
Okay, thank you. Any questions from the committee?
Sorry, I was late.
That's okay.
I apologize, I had a bill.
That's time of year. Thank you.
You're welcome.
Jenny O'Higgins? Oh, hi, welcome.
Thank you. Thanks so much. I'm Jenny O'Higgins. I'm the legislative liaison at DHHS for the Division for Behavioral Health. And I just am here to provide any information from the department. We had a couple of pieces in here around the language changes that we had worked with the commission on. I think the senator has already talked a little bit about why those are needed. In particular, some of the pieces that are correcting just best practice language to help people to access care based on how we talk about substance use disorders. The inclusion of harm reduction and the changes in words terminology like detoxification, change to withdrawal management, and medication-assisted treatment, change to medications for substance use disorder. So those are all pieces of language changes that are really just bringing the language up to speed with what is evidence-based best practice. The pieces that we would just request in here, just respectfully request that line 8 has the commission as having sole discretion on how many times the department shall solicit applications. We'd like to just work in collaboration with the commission to make sure that the department has the capacity and ability to put out those solicitations as many times a year as the commission is requesting. So that if that could be a collaborative relationship, that would be really helpful to the department. And then you'll also see in here that we have added a need for a few positions to manage the fund.
Senator Prentice.
Thank you, Senator Birdsall, and good morning. Thank you
Morning, thank
for
you.
being with us. I'm hoping that you can answer, or someone else in the department can answer this question. On page 3, number 17, in addition here, support secondary and tertiary prevention through harm reduction programs. Can you clarify and give an example of or examples of what that might be?
Sure. So tertiary prevention is, primary prevention is typically before someone initiates use, and secondary prevention is when someone is in active use, and tertiary prevention is meeting people where they're at when they're currently using drugs. So harm reduction programs are opioid overdose prevention. They can include things like naloxone distribution, as discussed by the previous speaker, and they can include a range of basically harm reduction is things that you would think of as wearing a seatbelt, a bicycle helmet, right? These are in public health. So when you're meeting people where they're at with people who use drugs, it may be that they need to come in out of the cold. It may be that they need wound care in a homeless encampment. It's such a wide variety of things about just reducing the harm to folks so that they can go on to get well.
Follow up, thank you. Would this include, say, needle safe injection sites and clean needle exchange programs? I don't know what the appropriate terminology is for that.
This would allow what's already allowable under the law. So at this
Okay.
time, we don't have safe injection sites in the state of New Hampshire. We do have syringe services programs, although how funding can be utilized from federal or state funds is limited. So it would just open up that this funding could be used for what's already allowable.
For already allowed. Thank you. All right.
Sure.
great.
I have a couple.
Okay.
Would you have any knowledge as to why non-for-profit providers were taken out in the language on line, page 1, line 28?
So my very best understanding of that is that it was never intended to be eligible for reimbursement, that there were 3 categories that were only eligible for states and political subdivisions. So you'll see that it sounds like in the following page, page 2, line 1 and line 11, those numbers 2 and 5 are written that reimbursement can only be for states and political subdivisions. And my understanding was that this was, for lack of a better term, a typo, that was how it was supposed to be written, is that the reimbursement could only be for states and political subdivisions. And that the RGA, our request for grant applications, was adjusted, and that it just needed to be revised in statute.
So based on the previous speaker, Attorney Buffetti, there are nonprofits that are able to get reimbursed for it. So are you saying that they won't be?
I think that if
Based
we're
on
under
this line?
reimbursement, they wouldn't be the way that this is written with the strike. So I think that's something that I could go back and gather more information about to see how we want that language to land in collaboration with the commission members.
Okay, thank you. One last question. When you said working collaboratively with HHS and the commission, do you want additional language in there authorizing it, or is it understood?
So I think the department would respectfully request on line 8, where it reads, the commission shall have sole discretion, that we would like to have that changed to, will work collaboratively with the department as to how many times the department shall solicit applications.
Okay,
That would be the
I got the
language
thumbs up from the
change.
senator, so.
Fewer words.
We'll
I'm
work
not
on
known
that.
for brevity, so maybe we could adjust.
All right. Any other questions from the committee? Seeing none, thank you.
Thank you.
Kate Frey? Welcome.
Thank you. Good morning, members of the committee, and Happy New Year. I will be very brief. My name is Kate Fry. I'm the Vice President of Advocacy of New Futures. We support Senate Bill 32, and thanks Senator Rosenwald who's brought it in. I'll leave you written testimony. We are focusing on supporting the addition of language around evidence-based, evidence-informed primary, secondary, and tertiary prevention programs. I did include a little graph of what that means too. That might be helpful just to refer to later. And of course, we support the language as far as connecting with, working in coordination with the Governor's Commission on Alcohol and Other Drugs, because they are the entity who establishes a statewide plan. So it just makes sense to have coordination to make sure we're funding, have a complete funding picture for substance use in the state, substance use disorders in the state. And that's it. We support other parts of the bill, but that's what we're focusing on in our testimony today.
Thank you. Any questions from the committee? Seeing none, thank you.
Thank you.
It's a, I can't read the first name, Bagley? Welcome.
Good morning.
What's your first name?
It's Bobby.
Oh,
Bobbie.
got it. Okay.
I write
Now I
very-
see it.
Yes, I write very curly.
Welcome.
Thank you. Good morning. My name is Bobby Bagley. I am the director for the City of Nashua's Division of Public Health and Community Services. I am also one of the commission members on the Opioid Abatement Commission. And I'm here to speak in support of this bill. The importance of this fund continues to support the efforts of prevention, treatment, and recovery from opioid use and misuse. At this time, we are experiencing an increase in opioid overdose deaths with a projection of numbers that look similar to what they were when we were seeing earlier in the epidemic. The funding allows for many of the organizations to meet a head-on need in our communities and to respond proactively. Based on our lessons learned over the past years, we know that prevention works and we know that recovery is possible. Services need to be available at every avenue of contact, and the opioid abatement funds allows for our state to be very responsive to what we're seeing in our communities with regard to opioid overdoses. As a member of the commission, the changes that are here allow for us to be efficient in the distribution of these funds. And so I'm here to speak in support of that, and we'll take any questions that you have as well. On the boots on the ground level, what we need is to be able to continue to build capacity in response, and the funds allow for that to happen. As much money as we can get into the hands of the organizations that are providing the services as quickly as possible allows for us to stop what we're seeing with regards to the opioid deaths. Prevention allows for us to stop this earlier on before we get to the Ms. Higgins mentioned the secondary and tertiary efforts that are needed. Prevention allows for us to, at the very start of this, take a look at what's happening within the communities and with individuals who may have adverse experiences in their life that then allows for decision-making to lead to the use of substances that then can lead to addiction. And so, again, in support of this, the opioid abatement trust fund and the distribution of funds as expediently as possible is necessary. Thank you.
Any questions from the committee? Seeing none? Thank you. Okay, that concludes the speakers. Is there anyone here that would like to speak that has not had the opportunity? The only question I have, and I go back to the not-for-profit providers. Senator Rosenwald, do you have a potential?
Well, my thinking is that because this is about reimbursement for medication treatment, I think that's done by physicians, not for profits. I mean, you need to have a physician prescribing that treatment. So that's my thinking on just removing not-for-profits from that section, because that's only about reimbursement.
Oh, okay, so,
And basically it takes out the states and subdivisions and then puts them back. Community health centers, though, do have physicians prescribing, so
yeah, hospitals too. So, I'm going to suggest that we keep the community health centers. I'm not, and keep the not-for-profit providers out of the reimbursement?
yeah, I mean, because this is just about reimbursement.
Okay.
It's, so we require in state law all of the county jails to provide medication for substance use disorder, but we have not funded it, although the state requires it.
Okay.
I think but this would allow the counties to receive reimbursement for expenses
Okay.
that they are providing.
Okay.
And the state prison also does treat people with Suboxone and methadone and some other things. This would allow for reimbursement. So these particular lines of one are only about reimbursement. So
Okay.
I'd be fine with keeping the community health centers in, but I can't think that there are nonprofits that are prescribing these because physicians need to prescribe them.
But aren't hospitals nonprofit? A lot of hospitals are nonprofit.
Most are, some
Yeah.
are for profit, yeah.
Most of them are. I don't know that we should be reimbursing them. This doesn't prevent them from applying for grants.
Okay.
This is only about, here's what I spent this year. You need to pay me back. And I think for the subdivisions, we really need to pay them back.
Okay.
And the state, because we've spent a lot of money on this in DOC.
Senator Prince.
Thank you, Senator Bridzel. And Senator Rosenwald, I don't know if this is for you or for Attorney Buffetti. So page 2, line 1, I was looking at line 1 and line 11. So reimburse the state and any political subdivision for emergency response services related to opioid use disorder and any co-occurring substance use disorder, mental health issues provided by law enforcement and first responders. And I'm thinking the first responders are both, fire departments that provide EMS and emergency medical services. And there's a different line that has to do with political subdivisions for the cost of administering Narcan. So I'm thinking that 2 isn't just about Narcan, that 2 is about a broader set of services. Is there any context that you could provide to that? Are we thinking about what it might be in the future?
Well, I might be wrong, but I would interpret 2 as if a community says our firefighters are traumatized, we'd like to provide some mental health counseling for them, that would be allowable under number 2. Nobody's disagreeing with me, but the naloxone is more specific, as you can quantify the actual cost per dose. So I think 2 is broader in that it could include services that the cities and towns feel would be helpful for their first responders.
Would you believe that the first responders, being the chair of the Commission on PTSD, the first responders do have, they're starting to get out, doing outreach to their first responders with regards to this.
Okay. So can I do just
Follow up?
perfect? Thank you, Senator Britzel. So this is reimbursed, but could a state and could a local subdivision or a fire department and emergency medical service unit come forward with a project and apply for a grant that would, work in this area? Because the next, after 2, there's 3, which talks about mobile intervention. I just start to see these things like separate, but as coming together, and where we have these folks pre-positioned well in the state, they're meeting these folks on the front line. And maybe this is an offline discussion for some fine tuning, but I see this as an opportunity to support some initiatives locally that could really benefit those that are suffering and the departments that are already responding to it. And now they feel like they'll have something that tangible, a program that they can work through.
I believe it would allow that.
Yeah, perfect. Okay, that makes sense.
I love it when you say perfect.
Perfect.
Any other questions from the committee? All right, thank you.
Thank you very much,
Coming back
Madam
again.
Chair.
If there are no other speakers for Senate Bill, thank you, 32, I will close the hearing on 32.
Are we on to 35?
Yep.
I don't know why we would not allow reimbursement for hospitals or community health centers.
They have enough money. This is with the communities that don't. I mean, that's,
Sorry, I'm late. I had a bill.
I know. Okay, we will open the hearing on Senate Bill 35 relative to RSV vaccination administration. And again, welcome Senator Rosenwald.
Thank you, Madam Chair. For the record again, I'm Senator Cindy Rosenwald from Senate District 13, which is in Nashua. And I'm pleased to introduce Senate Bill 35, which anticipates FDA approval of a vaccine against RSV this spring and adds it to the list of vaccinations that adults may receive in pharmacies. As we've read in the news, RSV is a disease that mostly affects children and has led to an increase in pediatric hospital admissions, but it's also among the highest causes of respiratory illness death in older adults. And when this vaccine is approved, my understanding is it will be approved for adults over the age of 65. Allowing adults to receive vaccine in pharmacies has been authorized for 15 years. I think I was the original sponsor over in the House. It's convenient and it's less expensive than getting vaccinated in a doctor's office since there's no need for a copay or coinsurance payment. And saving time and money is a good way to encourage more adults to get recommended vaccinations. This bill has the support of the Board of Pharmacy. I'm not sure if they're represented here today, but they did vote recently to support it, and I hope the committee will look favorable on it. Thank you, Madam Chair.
You're welcome. Any questions from the committee? I do have one. Since this isn't approved as of yet from the FDA, could the effective date be changed just to 30 days after the approval date of RSV?
It certainly could.
Are they giving them out now?
They wouldn't be able to give it out before it was approved, even if the bill had become effective. You could do that. It's anticipated that it will have a May
Right.
approval. I mean, who knows when that will be? You could do that. I think when the bill originally came out of drafting, OLS had put 60 days, which was for this kind of bill, they're normal. And the representative of the company that will manufacture it asked us to make it on passage so that as soon as it was approved by the FDA and was shipped, it could be available only to adults. And I think only to adults over 65.
So I'm presuming then, and correct me if I'm wrong, that by the time it gets through this body, through the other body, it's going to be at least April or May anyway.
And I mean, typically it's June or July when
Right.
bills get signed. So if that's the case and it's been approved in May,
It's effective
pharmacies
upon
still would
passage.
not be allowed to give it until, let's say, July when the bill was signed. So that's why I put it as on passage.
Okay, thank you. Any questions from the committee? All right, thank you.
Thank you.
Everyone is in support. And Bruce Berkey? Oh, yep, you said no, I'm sorry. Laura Anderson? Welcome. Good morning.
Thank you for listening to me today. My name is Laura Anderson. I'm a nurse practitioner. I have been a nurse for over 30 years and a nurse practitioner for 15 years. I am currently employed by the Concord School District as the nurse practitioner and healthcare coordinator. So I would like to offer my personal and professional opinion regarding this bill. I am in full support of this bill. As a healthcare provider, I have seen many things over my years that I sometimes would care not to see, but I do what I do because I love what I do, and I will never leave this profession until I am old and gray. So, as you know, the bill, when passed, would enable pharmacists, advanced pharmacy techs, and pharmacy interns to administer the RSV vaccine to adults. Currently, when I worked at New England College, I worked there for 10 years, and we ran multiple vaccine clinics for meningitis B, for flu, for COVID, and other vaccines as well. And we could not have done that without the help of pharmacists. We would run vaccine clinics. They would come to our campus. We run vaccine clinics in our district for our employees so we can meet where we are working. And it's the pharmacists who are giving us our vaccines. And again, it helps so much with getting people vaccinated appropriately. I can't say enough about our pharmacists. They make our world a lot better and healthier. I would highly encourage you to discuss broadening the legislation to mirror the 47 states in our country who allow pharmacists to administer all vaccines as long as they are CDC and HIP recommended and FDA approved. This will allow pharmacists to administer all vaccines that are approved, and by doing this, New Hampshire would not have to continue to bring up legislation to bring forth another vaccine that yet we have to go through and allow pharmacists to administer. It would kind of bring it in a little bit faster, I think, without having that legislation. If there's something that's been approved by the FDA and by CDC and HIP, I think we should just go ahead and go for it. But again, that's my personal opinion. I am not a legislator, I'm a healthcare provider. So from my perspective as a healthcare provider, I do feel that we need to provide as many avenues as we possibly can for people in our state, whether it's from birth on up to 110 years old. We need to provide as many opportunities as we possibly can for them to get the appropriate vaccines to keep them healthy. And that's important for our state. We know what COVID did. We know we were two years of masking, and that's actually why we're starting to see all of these other diseases like RSV arising. Right now, Dartmouth-Hitchcock is over capacity by I think about 10%. They have a staffing shortage with nurses, and they're having a surge in RSV cases. RSV used to be a childhood disease, a childhood illness. If permitted, I would like to share my own personal experience with RSV. My son was 8 months old when he had RSV. I've been a nurse for a long time already. That scared me. As a mom, take the healthcare provider out of my head and put me as a mom, I was very scared for my child and for his life. Took him to the pediatrician, received a nebulizer treatment. His lungs didn't sound great. We went home, and within 1 hour, we were back at the pediatrician's office. And then we were going into the hospital for a direct admit to pediatrics. And my son was 8 months old, on oxygen, and having a difficult time breathing. Hopefully, as we go forward and as the vaccines develop and come out, this could be prevented for children as well as adults. We're seeing a lot of diseases now, like RSV. A lot of these people going in are adults. We don't see that usually in adults. That's a childhood thing. So this is very concerning to me. The faster we can get vaccines into people's arms, the better off we are. So from my perspective as a mom, watching my son struggling to breathe and being on oxygen, it was difficult. Even as a nurse, it was difficult because I had to take the nurse out and become a mom. And it was very difficult. Thankfully, he recovered, and he's currently a freshman in college studying aerospace engineering with a focus in astrodynamics. Out of my wheelhouse. So again, RSV is typically a virus that affects young children, but now we're seeing so many adults with RSV. I know that there's a vaccine coming. It's just a matter of having to go through all the processes and trials and things like that. So, and as we get older as adults, we typically, and children, they can bounce pretty well. we don't bounce as well as we're adults. Some RSV facts for you. Respiratory syncytial virus, RSV, is highly contagious. It's a virus that is usually mild but can severely affect the lungs and respiratory airways of adults as well, especially those who have already have lung disease in some shape or form, or heart disease. RSV can spread from a cough or a sneeze and can be contagious for as long as 4 weeks. So that's a lot of what we call the viral shedding. In the United States, there's approximately 177,000 hospitalizations in older adults due to RSV that are reported each year, and approximately 8% of cases result in death. I expect that this winter, that number will rise exponentially. And currently, the surge of RSV infections is straining capacity at the hospitals and is also a host to burnout in the nurses and the health providers that we have. In summary, we need to make vaccines available to all New Hampshire citizens, but especially for our homeless, our underserved, underinsured, and rural citizens. These are sometimes the populations that have the hardest time getting access to vaccines. We're beginning to see children and adults with vaccine preventable illnesses, including polio, measles, and mumps. These are all vaccine preventable diseases. Let's work together to turn the ship around and provide the proper channels that we need for people to receive their vaccines. I'll modify the words of Smokey Bear for you. All of us can work to decrease vaccine preventable diseases and outbreaks. How do we do this? I'm going to offer some suggestions to the panel. Let's provide specific locations to all New Hampshire, for people to get their vaccines. Let's consider vouchers, a reduced cost vaccine, rides to pharmacies. Let's get the mobile van back to going again, like we had during COVID times, to bring vaccines to people. They could go to a place like, they could go to some of the assisted living areas. They could go to individual, neighborhoods, things like that. Just as we did for those COVID vaccines. By allowing the pharmacists, the advanced pharmacy techs, and pharmacy interns, we can make this happen. I am confident in that. We can also make this happen by becoming the 48th state that allows pharmacists to administer all CDC, HIP, and FDA-approved vaccines. That will go a long way to keeping our great state, of which I love, in good health. Thank you for listening.
Thank you. Any questions from the committee? Seeing none, thank you.
Thank you.
Rick Newman? Okay. Glenn Perrault? Welcome.
Thank you. Hi, my name is Glenn Perrault. I'm here to speak in favor of this RSV immunization bill. I am a pharmacist and a community pharmacy owner. I have been immunizing for over 8 years and have administered thousands of vaccines. I currently work under a physician's protocol, which allows me to administer vaccines down to the age of 3 years, which we do. I've run several vaccine clinics at both private high schools and area businesses, and I feel that allowing community pharmacies to administer vaccines has greatly increased access to vaccines. And I don't see any reason why we can't add this vaccine to our list of approved administrations.
Thank you. Any questions from the committee? Seeing none,
Thank you.
thank you. Steve Cavadine? Cavadine, sorry.
That's all right.
Welcome.
Thank you. My name is Stephen Cavadias. I also am a pharmacist and a community pharmacy owner. I do support this bill, as we have shown, especially during the COVID times, that we are a great access to the community to get these in their arms. I also support opening it up to all approved vaccines, and I think there's other opportunities that that can be presented at future times to help improve more pharmacies to be able to give more vaccines.
Thank you.
I have nothing more to add other than to agree with a few people here.
Thank you. Any questions from the committee? Seeing none.
Okay,
Thank you
thank
for your
you.
time. Except for Rick Newman, that is all that has requested to speak. Is there anyone here that has not been given the opportunity but would like to? I called on you first, Bruce.
Yeah, he wasn't, said no.
I know. Welcome.
Thank you, Madam Chair and members of the Senate Health and Human Services Committee. My name is Bruce Berkey, and I represent the Coalition of New Hampshire Chain Drugstores. And I was not planning to speak, but hearing some of the testimony that came before me, we do have a letter supporting this bill. It also provides a suggested way of accomplishing what this forgot her name, the school nurse, and this gentleman just shared in terms of not having to go back and change the statutes every time there's a new vaccine available. If it's FDA approved, if it's CDC approved, so forth. So I have that. I'll leave that with Cam, and that concludes my testimony. Thanks.
Thank you. Any questions from the committee? Senator Bradley.
Maybe I should have asked this of the pharmacist, but what vaccines do we not currently allow pharmacists to administer?
I don't have that list at the top of my head, but I can certainly give
Are
it.
there any?
Well, there's some that I do not give, just because of a staffing issue. So I provide the most vaccines that are needed in my area. Do you have any?
Why don't we,
I believe most of them.
Why?
why don't we switch out and
Right.
get you folks back up on the microphone?
And if you could introduce yourself again.
Hi, my name is Glenn Peralt. I don't have an actual list off the top of my head, but I believe that the majority of the vaccines are travel related. Typhoid, yellow fever, vaccines, malaria, the vaccines that would be administered at a travel clinic.
Any other questions? Any other questions from the committee? Seeing none, thank you. Is there anyone here that would like to testify? Laura, come on down again.
They should have a separate bill.
Welcome back.
Thank you. Laura Anderson again. I am not a pharmacist, as you know, but from what I have seen from the vaccine clinics that we have held, pharmacists are able to give a broad spectrum of vaccines. They can give the shingles vaccine, that's shingles. They can give the hepatitis B. They can give, they don't give the chickenpox vaccine at this point in time that I am aware of. MMRs can be given by pharmacists. Tdaps can be given by pharmacists. So it covers a good amount of vaccines that the pharmacists are able to give, which is fantastic. And to be honest, when I worked at New England College, we had a lot of students who came without vaccines, and they would just bring to the vaccine clinic. They would just, we had it during move-in days, and they would have a variety of vaccines, and they give out meningitis B, and that vaccine is just so important for preventing meningitis, especially in college-age students, combined with the meningitis A vaccine, which pharmacists can also give. So I think it's a very wide variety, and every pharmacy is different. The mom and pop pharmacies to their, I love those pharmacies. I go to one myself, but sometimes they are limited due to staffing and things like that. And even our regular pharmacies like Walgreens and Rite Aid are also limited in their staffing, but they have a broad variety of vaccines that they are able to give, including flu and COVID as well.
especially for the pharmacists.
Okay,
Thank
thank
you.
you. Can we have the pharmacists up again? Senator,
Yeah, just real briefly, uh, dumb question, maybe, but why aren't some of the vaccines available for the pharmacists to administer?
I honestly do not know.
Do you need
I'm-
a doctor's prescription to take these?
So at this time, we're not, even with a doctor's prescription, we can fill the prescription, but we're not allowed to administer it. There's a specific panel of vaccines allowed by New Hampshire law that we are allowed to administer. And right now, New Hampshire law allows pharmacists to work without a physician's protocol to administer to adults, which is 18 and older. The way my pharmacy is allowed to administer down to age 3 is that I have an area physician who signs my protocols that allows me to work under his supervision to administer down to the age of 3.
Thank you. That's all. I'm just curious as to why there isn't like a broad
Yeah,
ability to do so.
it has, the other folks ahead of me spoke. The vaccines in the state of New Hampshire are specific as to which ones we're allowed to administer. It was even so specific that one time with a Board of Pharmacy inspection, the law was specific to allow us to administer Tdap, not TD, tetanus, diphtheria, or just straight tetanus. It had to be Tdap.
Interesting.
Yeah.
Thank you. Thank you.
You're welcome.
any other questions? Thank you. Senator, you wanted to come back up?
Thank you, Madam Chair.
Yep.
I think, help with a little bit of the history of why we continue to add. Some of these vaccines are new, and generally it's been requests of the pharmacies that have come to the legislature over the year and said, we're doing this, it's good, it's adults, it's broad segments of the adult populations, it's not, malaria, which you would maybe need if you went to visit certain countries and not others, that you'd probably want to see an infectious disease physician to figure out if you needed a malaria or a typhoid, whatever they are, or I think it's now called Mpox, but was called monkeypox. That's another one. So there's some vaccines that are not given to the broad population. But I would say that over 15 years, I think we've learned that pharmacies are a great site for vaccines. So if the committee wanted to recommend that they be able to give all authorized and recommended vaccines, I'd probably be okay with that, but I would ask you to limit it to adults. When I first looked at this bill, I sent it to Dr. Ballard, who is the state's chief medical officer. And he said, we feel that it's very important for children to receive their vaccinations within the pediatrician or the nurse practitioner office setting, so that there's a real coordination of care. So I would ask, if you were going to go with the language that Mr. Berkey gave, that you not strike adults, but keep it as adults rather than the general public.
Any questions for the senator? Seeing none, thank you. Is there anyone else that would like to speak that hasn't had the opportunity? I will close the hearing on Senate Bill 35. Yep,
Do you want to exec it?
right now. I'd rather wait till after.
Okay.
I like that idea of having it kept to adults. I like it kept to adults.
Agreed.
Yeah, and maybe even under your like things.
All right, I'm going to open the hearing on Senate Bill, thank you,
36.
36. And welcome the prime sponsor, Senator Gannon. Welcome.
Thank you, Senator Pertzel. You guys are probably all more expert in this area than I. So for me, this has been an adventure and I've learned a lot. Senator Bradley and I both live in two of the best, most beautiful places in the world. He takes better pictures than I do, but I have thousands of feet of waterfront. My parents got to live in this house, and fortunately, they had my wife and me next door. So we got to do a lot of services, and my kids got to grow up with them. And things that normally, if you didn't have a relative nearby, my parents in no way could have stayed in this house as long as they did. My dad got to die there of cancer about 5 years ago. My mom got to stay till she was falling down with the Alzheimer's and couldn't stand up. So they got a wonderful life. But that was only because I had a great wife. Most people are going to need more services. And so I want to be able to stay in the same house. I got a beautiful place in Naples, much like Senator Bradley and Marco. But in the summers and most of the year, I want to stay in Sandown. Best place again. Oh, I'm sorry. I'm Senator Bill Gannon, District 23. I should have introduced myself. It's a little late in the adventure here. I live in wine country, right near your vineyard, Senator LaBelle, in your district, and I have Sorvinos. We're in the middle of wine country. But anyways, back to this. We need
Amy would have
community-based
something to say
services
about that.
because most people aren't going to have a family member and who can have one of the family with them night and day, day and night. We need to. And how are we going to do that? So I'm going to go to Jerry Maguire is how we're going to do that. It's when some of the people behind me said, I just saw that movie. What are you going to talk about? I'm going to talk about Show Me the Money. The federal government, between ARPA and the, which expires in 2026, and the Build Back Better Act, which, God, I didn't know there were so many good things in it. It was $924 million we were eligible for, and they were set it aside for us. We only got 724 million. That's not a good thing. It might have been even a little less than that. It was about a $220 million we left on the table. Why did we leave it on the table? We don't have the infrastructure to get the money. We don't have the people. And so a couple of the senators came to me and said, how much is this going to cost, Senator? I'm like, it's going to cost $320,000 in personnel, but we can get 220 million that we've left on the table. And again, one of the programs ends in 31 and one ends in 2026. So it isn't like it's a 1 year thing or a 2 year thing. We have 8 years of money in front of us. So I want to make sure we get every cent that we can for New Hampshire. I want to change the rules to give caregivers who are guardians or powers of attorney to become caregivers. I want people when they go in to be presumptively eligible for these funds. And again, it's 80% cheaper to have someone living at home. They're going to be happy if that's where they want to be. We're going to save a ton of money and they're going to get the services they need to stay there. Again, we need these 5 people. 310,000 is the estimated cost for 220 back. But so what we need to do is they have benchmarks. If you want the federal money, you have to maintain home and community-based service levels. You have to enhance the services. You have to pay at certain levels. And we certainly will have the funding to do that if we have the staff to apply. It's just, I was in East Kingston a couple of months ago, and they had a loader. And the governor came, and they put him on the loader, and I said, geez, and the guy said, yeah, most of the little stations didn't apply for this money. I did. I'm hawkish, and I want us to be hawkish for the federal money. If it's out there, we should have it coming our way. I am not an expert in this. I bet every one of you is better and have done more of this, from Jeb to about 100 years of experience there. Between all of you, there's a lot of experience. So I have learned a lot. I've seen how much can come to New Hampshire out of this program. And I hope that it's something you can all put your teeth behind and get into. And there are people who are much more learned than I in the field behind me. If you have any more detailed questions, they probably would be better than I to do it. So I was very humbled to be asked to put this bill forward. I said, why did you do this? They're like, well, you got the money back from the assisted age homes last year, and we saw you doing that. We know I'm going to be on the Commission for Aging. God, that means a lot. Senator Bradley didn't tell me it meets like 6 times a month. But I'll be okay. So again, I'm humbled to be here before you to present this bill. And if you have any questions I can do, or someone else behind me, that would be great.
Senator Avard?
Thank you, Madam Chair, and thank you for bringing this bill up. And I see I am a co-sponsor on here, and I am very sympathetic with the goals of this. My question is, though, once that federal money runs out, how much is New Hampshire going to be on the hook for?
Well, the Build Back Better funding, I said it's 8 years. The other money is like 4 more years. I didn't think of that question. So the people behind me coming up probably will know the exact figure. Well, the staffing fee now would be 310,000 plus, every year that's going to go up.
Yeah.
So there are going to be some costs to it.
And follow up, if I may? Thank you.
Follow-up?
And always worried about the feds just micromanaging our policies in New Hampshire. And does this open the door for them to micromanage what we do here without receiving all that money?
So there's always a cost. Yeah, sure. There's always a stick if there's a carrot. And so, yes, they will, again, they may be able to tell you better exactly, people behind me, how that's going to be. What policies, what's going to have to change. I don't know.
I really appreciate it. Thank you,
Okay,
Senator.
thank you,
Appreciate it.
Senator. Yes, Senator Prentice.
Senator Prentice?
I'm
Thank
sorry.
you.
I'm sorry. I apologize.
It's okay. And thank you again for sponsoring this and bringing this forward. I have a 90-year-old mother that actually is, she moved to New Hampshire last year and lives by herself at the end of my street.
Okay, she's
But I
doing
want
great.
her, part of this was for her to be able to be in a one level and to be able to stay there and stay close to family for as long as she wants to. So that clearly has my attention, and I appreciate the way that you opened this today. So just one question, because I think
Sure.
Senator Avard may have touched on my second question. 310 or 320,000 for personnel, is that per year or over the life of the funding that we're already looking at federally?
I am 99% sure it's per year.
99% is per year? Okay.
It is per year, I noticed.
All right. And,
Plus wage increases, as Senator Avard alluded to.
okay. And I want to work more on the benchmarks in a little bit, but I'll hold for now.
Okay.
Thank you.
Thank you very much. I'm off to-
Senator Whitley?
Thank you, Madam Chair.
I'm sorry, Senator Whitley.
Thanks for
Very
taking my
popular.
question. So, of course, cost is something that we always have to think about. I'm just thinking about the community-based systems that we built in other areas, right? We have spent years working on the children's mental health system, building up those community-based services so we can both get better outcomes for children, but also so we can save money, because having them treated in hospitals, acute psychiatric settings, that's more expensive, not as
Sure.
effective as the community base. So again, the mental health system, we did that with the developmental disability system. It does feel like this system is the last one, the last frontier in terms of building the community-based system. So do you expect those savings that we saw in other systems in this as well?
I do. And so the savings, so the cost is the 330, and it's like 6,000% more that we're going to generate, especially in the early years, maybe not in the later years. And yeah, I was at the DD wait lists and stuff when I first got into the Senate. I didn't even know what it was. And then I found out we had a problem, and Senator Morris and Senator Bradley made me aware. And again, anything we can do at home for these people. And again, I watched with my parents, you're seeing with your mom. Even the house I'm in now, my wife and I and our place in Florida, we're looking now, maybe we should have a place where it's either an elevator or not stairs up. So yeah, I'm looking at all these things to make life easier as I approach my golden years. Maybe I'm not quite there, but my children tell me I am. So, yeah, I think this program will be very good. So that Senator Bradley, who's a little closer than I am, will be able to stay on our lakefront, beautiful places, which are one story. But we're going to need a little help as we get older. And I think this will do that, or at least help do that.
Senator Prentice?
Thank you, Senator Bridgestone. Quickly, I think that what Senator Whitley just hit on is, kind of what Senator Whitley just talked about. We have a period of time here to not leave the money on the table, build out the services, and as we're doing that, we can find the cost savings that I know that we will see locally, regionally, and statewide, as well as, as we have done with these other services, find the ways to bring these programs into more permanency. I mean, that would be my ultimate goal, which is probably more of an executive session statement, but I just wanted to make it now so I see the balance there. Okay, thank you.
Oh, my Jerry Maguire references which I didn't get to. I missed the whole thing. I got to get more sleep. Show me the money, right? We went to And then help me help you. It's like the federal government will have them, if we set up the positions, we'll be helping ourselves get the money. Help me help you. Those are the two themes from Jerry Maguire that I got. Anyways, have a great day.
I have
Thank
a
you.
question. Senator, I have a question.
Can't go, can't go.
I didn't see you.
I'm just invisible. Thank you.
No, I saw you. I'm always looking at you. Yes,
So
ma'am.
you gave the price tag of 310 and then 330. Where did you get those numbers? Because we don't have a fiscal note, and it is a fiscal note bill.
It is a fiscal note. I got it from some people who are going to testify right after me. And so I'm
Okay.
sure they were very copious and diligent in their arriving at that 310. So they had the cost per position. One cost was the three ombudsman at grade level 25 was $51,558. So it totaled 154. One intake at grade 20, step 1, 41,805. A deputy ombudsman at grade 26, step 4 was 61,172. And one person at grade 25, step 1 was 51,580. Salesforce development app was 10,000, and that's where they got the 310. But I wasn't going to bore you with those details.
Thank you. Senator Bradley has a question.
Yes, Senator.
Yeah, that was my question. I'm looking at the office established on line 18.
So I
page
don't know if
7.
it's in the paperwork you already got, or they'll provide it with you.
All right, so
momentarily.
the 5 positions that you
Yes.
cite are not in the bill.
They are not in the bill.
Okay.
And they were 300 plus the 10,000 for the software. All right, was the 310.
Any other questions from the committee? Seeing none? Thank you.
Thank you. Off to you, Dina.
Melissa Hardy and Wendy Altman from DHH. Okay, thank you. So let's start with Amy Moore. Yep. Good morning, welcome to HHS.
My name is Amy. Oh, thank you. My name is Amy Moore. I'm here on behalf of the Home Care, Hospice, and Palliative Care Alliance. I chair their legislative committee. I also am the director at Accentria in Home Care. And here in support of this bill, certainly we are really excited about many of the pieces in this bill that will work to stabilize this system of care that is currently in crisis. And I just want to speak to while all of this is really exciting and will do a lot to stabilize the system, we need to first recognize that the system is in crisis. I can tell you that I and others behind me were here 10, 12 years ago warning of this. At Accentria in Home Care, we serve nearly 400 clients throughout the state. And I started as a caseworker, I've never seen the things this bad. We are at a point where we have people dying because they're going without care and our caregivers are finding them days later. We cannot have people that are laying there dying because we're not paying a livable wage. And I really think what's happened is if you look, New Hampshire Fiscal Policy Institute recently had a wonderful report, and in there they talked about the fact that this CFI system has been underfunded by over $153 million since 2011. And because it was neglected over time, we're now in this space where we're turning away people every single day. And we serve people 18 to 102 right now. And I can tell you that nearly 60% of my census is actually under age 70 and not really appropriate to be at a nursing facility. Nursing facilities are overrun because, and hospitals are overrun because they can't discharge to us. So it's a system of care that really needs to be invested in. And I just hope that we can recognize that while all of this is wonderful and I am fully in support of it, that we really need to make major change. And I just want to add that we did with the ARPA funding, we've been tracking data to see, because there is that question of like, we're in a workforce crisis, right? So if we give you more money, what's going to happen? Well, we've been tracking during the long-term care stabilization funds and the ARPA funding. We were able to invest in mentoring for our staff and give them stipends so that they actually had somewhat close to a livable wage. And we were able to serve more of our people out in the field. Thousands of hours we were able to serve because we invested that money in them. My daughter's 14. She makes more babysitting next door. This is a problem. And I think and until we address that, we're just going to be putting these Band-Aids on. So I just really implore you to support this bill. Wonderful stuff going on here. I'm very excited about all of it. But we really need to look at the big picture and invest in this program.
Thank you. Any questions from the committee? Senator Whitley.
It's horrifying what you're describing, right? It's absolutely horrifying. And I just, it takes my breath away. I think I've been aware that this system is in crisis, but to hear you speak so plainly about the fact that our older residents who have contributed so much to our communities and our state, that they're ending their lives in such a disrespectful way, frankly. And so it's horrifying. And I'm just wondering if you had any insight into how we got here.
How it got here was we spent close to 15 years. So there's rate setting rules in here. And one thing that I love about this bill is that it addresses that. There's a rate setting rule. And what's happened is that has been suspended year after year. Nothing's been done with it. So these rates have not changed significantly over the years. So if we had just invested each year a small amount to this, we wouldn't be here. But we haven't. It's been neglected. And I think that really reflects really poorly on New Hampshire, that this is how we treat our people. And I'm sick of you guys having to look at me. Frankly, I hate this. I want you to see my 400 people, but they can't get here. Can I tell you quickly, I started as a caseworker out in the field. I just had my daughter. I was a single parent, knew nothing, didn't know what I was doing. And I knocked on this door one day of this new client I was doing an intake for. And I was so thrown because I was 28 and he was the same age as me. He's a handsome, buff guy in a wheelchair. And I said, "What happened?" And he said, "I'm a roofer. And I was just finishing up a job and the temperature dropped and it was drizzling. And he fell and now he's a paraplegic." So we served him for many years. I ended up becoming friends with him. And about a year ago, he had to leave our agency because his caregiver moved. We didn't have anyone. So he went to another agency. I got a call a couple months ago. This guy who was the same age as me, I'm 42, had been found dead. He didn't have care, and he tried to transfer himself from his wheelchair to his bed. And he laid there for 3 days. I have so many of these stories. 100-year-old veteran that couldn't come home. I didn't have anyone for him. CFI is so much cheaper than a nursing home and more appropriate for a lot of people. They do better. Why aren't we investing in it?
Thanks. Any other questions? Thank you.
Good morning. My name is Keith Kinney. I'm the Advocacy Director at Waypoint. We also sit in support of the bill, but we think it would be remiss of us not to talk about what's happening with our CFI program. We serve 200 people currently, and we have stopped taking referrals. We can no longer take referrals for the CFI program because we can't find the workers because there's just not enough pay. And I know that Amy, we had talked about this before. I think she's at a point where the majority of the people that she is hiring are family members because with the current rates, we can't find people to hire. And so we're at a real crisis point. We're going to look in July and see and evaluate whether we can continue this program or not. But the greater chances are is that we're going to have to tell DHHS that we can no longer handle the 200 people. And where those 200 people are going to go, I don't know. We try. We raise over $500,000 a year in order to keep this program going. And without that money, we'd have no program at all. So we're in a crisis stage. You know, these are our elderly. We should be taking care of them. And I think what Amy said is very true. You have to think of this as a system. The CFI acts as a filter between the hospitals and the nursing homes. So I talked to Courtney Gray Tanner. She said they have 60 people at Dartmouth Hitchcock, virtually an entire ward, where they can't discharge people because there's no place to discharge them to because there are no CFI programs. So CFI is supposed to act as this filter between the hospitals and the nursing homes that allows people to be discharged, that can be discharged into their home. They're happier there. It's cheaper there, and it doesn't overwhelm the already burdened nursing homes. And you know, you lose CFI, the entire system is in trouble. And so I would agree with Amy, and I said this out in the hallway. I feel like this bill is wonderful. It also feels like we're rearranging chairs on the deck of the Titanic, because if the underlying program isn't there, all of this is moot. Right? We have to have the program and have to have these new things that this bill provides. And without them, if we don't have the underlying program, it's all gone. So thank you for your time, and I'm happy to take any questions.
Any questions from the committee? Senator Bradley.
So looking on page 3, in particular, lines 10 through 14, which is the rate setting mechanism that the department goes through. What is going to change by this in terms of setting the rates for the CFI program for providers? How is this going to be different than the process that we have today?
We're basically asking that our legislature honors what's written and that we can't, so these rules just keep getting suspended and the rates aren't addressed. And so we need to bring them to up and make up for the 15 years of neglect, and then each year actually honor this and not suspend those rules.
By lines 13 and 14 to align with CMS?
Yes,
The
that's my
market
belief.
basket
Yep.
index? Okay. And I don't know if this is a question for you or for the department, but how far under the current market basket index are New Hampshire rates today?
There's actually a great New Hampshire Fiscal Policy Institute has a great that shows that, and I don't have the exact number, but I know that
That would be
I'm going to
helpful.
say what Senator Gannon said. Someone behind me will know that.
Senator, if it's all right, Senator, I will tell you what we're asking for is that the CFI rates be brought up to the Title 20 rates, which is about $4 or $5 an hour. We can make Title 20 work. We can't make CFI work because Title 20 has less care, less professional care. And so it's upside down as it can be. The people that need to provide the highest level of care, we're getting paid $4 or $5 less than the Title 20 program. And so what we're doing currently is we're having to take on more and more Title 20 people because there's no reason not to use the people that we have. But you have to understand, every unit that we provide under CFI, we lose money. And we lose tremendous amounts of money. And this is just unsustainable for us. And, you know, when you start talking about raising $500,000 a year, if we could get the CFI rates up to Title 20 and then index them so they continue to grow, I think we would have the problem mainly solved. I hope that answers your question.
If I might, you know, give, just for your agency alone, Keith, what would that cost be to go from CFI to Title 20 on an annual basis?
I can get you that number. I'm not exactly sure. It's not, I will say this, Senator, thank you for the question. It's not cheap. You know, I think the fact that we've neglected the program for so many years, we're behind. And, you know, I mean, to come in and ask for a $4 or $5 an hour increase is a lot. We know that. But I would agree with Amy, you know, when you drive by McDonald's and it says 14-year-olds are being hired for $14 an hour, and we're paying our people $11.50 or $12, you can imagine that we just can't hire the workers. And I think what's most heartbreaking about this is the workers that want to serve these elderly, they are some of the greatest people in the world. They see these elderly people as part of their family. They walk in and they care about these people in the most deep way, and they're willing to take some sacrifice in order to provide this. I mean, we have to stop hiring people at 29 hours because we can't even, under this program, provide insurance for them. That's where we are. But you give us enough money, we'll get the staff to take care of our elderly.
Yeah.
We can do that, and they want to do it.
People want to do this work.
Yeah.
We have so many people that are heart in tears crying, leaving because they can't put food on the table. So they have to go take a job somewhere else.
Right.
And some of them eventually come back once we have a stipend or something to help them. But there are people that want to do this work. It's so rewarding. But if you can't, I mean, $14, $15 an hour. I mean, have you gone grocery shopping recently? You know, it doesn't work.
Well, they see it as a calling. You know, they see it as a true calling to help the elderly. But at the same time, they have to balance their needs with their family also.
And I would just like to add, part of this, Borja, the, CEO at Waypoint, and I have talked, it was during COVID at one point, the two of us were on the phone saying, what do we do next? Just in tears, because we're at the point, frankly, where it feels like we're exploiting these good people who are willing to do this work. Because they're now a part of some of them are getting state funds because they don't make enough. I mean, it doesn't take much.
Any other questions from the committee? Seeing none, thank you.
Thank you for your time.
so much.
Jess Esklin?
Good morning, Madam Chair, Mr. Vice Chair, members of the committee. My name is Jess Eskeland. I am the Senior Public Policy Manager for the Alzheimer's Association's New Hampshire, Massachusetts chapter. Pleased to testify today in support of this bill. On behalf of the Granite Staters living with or caring for someone with Alzheimer's, I respectfully urge you to support this legislation. As of 2020, there were approximately 26,000 Granite Staters living with Alzheimer's and another 58,000 caregivers providing unpaid care for these folks. This number is projected to go up 23% by 2025, meaning 32,000 Granite Staters at least will be living with Alzheimer's. So it's more important now than ever that we're addressing the needs of these individuals and their families. I know folks are here to speak in depth about the bill. I just wanted to highlight a few points. The association supports the expansion of financial eligibility for Medicaid, adult home, and community-based waiver programs that's included in the bill. The duration of Alzheimer's combined with the high cost of care means most people with Alzheimer's will eventually have to rely on Medicaid for support. By expanding eligibility, we're going to allow more folks to access the critical services that they need. We know financial eligibility for Medicaid can be really complex, and folks trying to access these services, either for themselves or the folks that they're caring for, often find difficulty in this process and report long waits for documentation and approval, and difficulty finding the right information or methods for applying. These long delays often mean that people aren't getting the timely services that they need, and so the association supports the expansion of presumptive eligibility in the bill. We very much support the expansion of ServiceLink. Folks living with Alzheimer's as well as their caregivers will hugely benefit from increased staffing to expand ServiceLink's capacity to provide long-term care counseling services to these folks. Bolstering availability of these services will allow more Granite Staters with the disease to enjoy more independence and empower them to make decisions about how and where they live and age. Furthermore, we very much support the provision stipulating the Medicaid waiver program rates be adjusted each biennium based at a minimum upon the CMS Market Basket Index rate. By ensuring these rates are consistently assessed and when needed adjusted, the bill stands to ensure long-term care facilities are able to attract and retain a robust workforce, which is incredibly important as you just heard and will hear. In closing, all Granite Staters deserve to age with dignity and make as many decisions as possible about their own care. And passage of this bill will go a long way toward accomplishing that goal and really meeting folks where they're at. So that concludes my testimony. I have copies for Cam, and I'm happy to try to answer any questions you might have.
Senator Abar?
No.
Any questions from the committee? Seeing none, thank you, Jess.
Thank you.
Christina Fitzpatrick? Cam, can you, Christina Fitzpatrick's outside. Oh, thank you. Welcome. Good morning.
Oh, we are grateful to Senator Gannon and all the co-sponsors for introducing the Systems of Care for Healthy Aging bill. AARP is fully in support of this bill. I would like to convey 3 points to you today about it. One is that the current system for long-term services and supports in New Hampshire is heavily weighted towards nursing home care. And as you've heard, that's not what most people want, and it costs a lot less than care in a nursing home setting. New Hampshire is really far behind when it comes to spending money on home and community-based care and balancing the spending with nursing homes. So for example, New Hampshire spends only 14% of public dollars for long-term services and supports, spends only 14% of that on home and community-based services, and that puts us 50th in the country. We can do better, and we need to do better because of the aging population in New Hampshire. The New England average for the percentage of public money spent on community-based care is 36%, and the nationwide average is 45%. So at 14%, New Hampshire is really far behind, and we need to make improvements in that. The bill will do that. It will make great strides in trying to provide more balance to the system, and it will make it more feasible for people to age in their homes. We need to make high quality, affordable in-home care possible and a priority. New Hampshire, AARP New Hampshire is fully behind this bill, and we, together with all the volunteers who you see behind me in red and many more in the lobby, we will be working tirelessly this year to make it a reality. Thank you.
Thank you. Any questions, Senator Whitley?
Thank you, Madam Chair, and thank you for taking my question. What really struck me was that 14% number. That's incredibly off balance. And again, I think, that gets to the cost issue, right? That the fact that we know that home and community-based services are less expensive than nursing facility services, yet we only spend 14% of our budget. So there seems to be like a big room for improvement, particularly if we are last and 50th in the nation in terms of our balance. So I'm going to ask a similar question to you. How did we get here? How is it that the DD system we're moving towards equal balance? The mental health system we're moving towards balance. How is it that we are so out of balance in this system?
There are a few answers to that question. One is that nursing homes are better set up to deal with some of this, the intake process. So for example, a lot of people who need this care will eventually qualify for Medicaid assistance with paying for the care, but it takes a while for that eligibility to be determined. And if you are a big organization, you can set up your finances to sort of absorb that cost. So you can carry a person for 3 months before Medicaid starts paying. But if you're a small home health agency, you just don't have the wherewithal to do that. So there is a reason that people might end up in a nursing home just based on that. There's also the case that the nursing home industry is better organized than small home health agencies, because the services that people need are fragmented among different agencies, and it's different kinds of organizations, and it's harder for them to band together. So there's sort of good policy reasons that are fixable that explain some of this, and then some of it is just it's politics and power.
Thank you.
Any other questions from the committee? Seeing none? Thank you.
Thank you.
Jill Martin?
Good
Welcome.
morning. I'm Jill Martin. I live in Dover, and I'm here in support of the bill. And as you can see from my red jacket, I'm an AARP volunteer, and I became a volunteer because Doug McNutt, sitting behind me, spoke several years ago at the Dover Library on the importance of advocacy. And so I wanted to jump into that and take on an advocate role. I'm also a caregiver for my 92-year-old mom. We realized the moment that my dad died that she couldn't live alone, mainly because he did all the cooking. Figuring out how to ensure that she continued to live a safe and fulfilling life was the beginning of my family's caregiving journey. Defining and matching her needs with available resources was our first step, and I soon learned the difficulty of locating and navigating through options. I was not prepared for what I needed to know and be and do when I began as a caregiver for an independently minded woman with limited mobility, low vision, and hearing. Last year, Mark, who's going to speak after me, and I and about 23 other people from around the state were part of a senior leadership program developed by AARP, the Center on Aging and Community Living, and Dartmouth Centers for Health and Aging. We've been introduced to state organizations like the Alliance for Healthy Aging and the Coalition on Aging, and learned about existing care and healthy aging options in the state. A feature of the program is a final team project. My 4-person group chose caregiving because our personal experiences of caregiving for family members. We began by creating a list of over 100 questions. I think we came up with like 120 to ask ourselves and our family member care recipient. All the questions had yes or no answers and were divided into several categories. So those categories included health, financial, care tasks, transportation, and home environment topics, to name a few. And here are some of the questions. Can you identify any training needs you have as a caregiver? Do you know where to get that training? Is there transportation to get your care recipient to medical appointments? Do you know how to budget? Do you know how to find in-home assistance? Do you know how much it will cost and how you'll pay for it? These are just a few of the 100+ questions that we came up with. We put these questions into a flow chart, and then we started searching for local and statewide services to provide help with our answers to these questions. That's when we discovered that we couldn't locate many of the resources needed to finish our chart. The bill's proposal to establish comprehensive and coordinated systems of care services will be a huge support for those searching for help, like myself, in their caregiving journey. As one of my team members said, caregiving is a great leveler. It can be isolating, it can be stressful. I think it can feel like trying to navigate choppy waters in a leaky boat and your passenger can't swim. I urge this committee to support this bill, which will be a lifesaver for older adults accessing systems to age well in this state. Thank you very much.
Any questions from the committee? Seeing none, thank you. Cheryl Steinberg? Welcome.
Thank you, Senator Bergsdale and members of the committee. My name is Cheryl Steinberg. I'm the director of the Justice and Aging Project at New Hampshire Legal Assistance, and I'm here today on behalf of the New Hampshire Alliance for Healthy Aging in support of Senate Bill 36. For those of you who might not be familiar, the New Hampshire Alliance for Healthy Aging is a coalition of stakeholders across the state that are focused on improving the health and well-being of Granite Staters as they age. For the last several years, the Alliance for Healthy Aging has been working on trying to get a better balance of our long-term care system for older people and people with disabilities, and for all the reasons you've already heard, so I won't repeat them all. And it is very important, you know, as we know, if given the choice and if appropriate, people really want to be able to remain in their homes to receive their care, and it is much more cost-effective to receive the care in their homes. And so for that reason, and because of the aging status of our state. You know, we're already the second oldest state in the country, and we're destined to become even older. And you've already heard how our capacity to serve the people already in the state isn't there. And so the need's only going to get greater, and we need to really do something now to really address the problem. So we've really been focusing on that. Part of what we've done over the last few years is work with the New Hampshire Fiscal Policy Institute, and you heard about how they have issued a report, and Doug McNutt is here today and can talk about the specifics in the report. I'm not going to try to get into the weeds on that. But it included many findings and recommendations about how we can try to improve the system that we have. And we've incorporated a lot of those findings and recommendations in the bill. I wanted to try to just take some time to explain the bill a little bit, because I know it's long and maybe it might help, hopefully, very briefly. I won't take a long time to go through it a bit for you. But we did base it on something that Senator Whitley talked about, the bill that's a system of care for children's behavioral health, which was a model that we thought was a good model to mirror, because it is trying to set a framework for how we can really improve the systems of care for healthy aging. Because as you correctly pointed out, it is kind of the last frontier here for our state. We have not focused on this population prior, really. So we wanted to try to do that. And we also, just for your information, we thought it made sense to put it within 151E, which relates to long-term care. But we also consider it to be intended as a standalone section for the systems of care piece, if that makes sense. So there's 8 new sections in the systems of care bill itself, and then there's proposed amendments to 5 already existing statutes. So within the new portions of the bill, there's findings, why we think this is necessary, which I won't go through, and you've heard a lot of it already anyway. The purpose is, which really is overall, the overarching purpose is to create a comprehensive and coordinated system of care for older people and people with disabilities, and increase access. I mean, really with the ultimate goal of doing that. We have a statement of policy, again, mirroring that. It's the same, the purpose, and then definitions, and important than definitions, some of them are just to help explain some of the provisions in the bill, but there is a definition of what we consider the system of care, what needs to be in the system of care to make it work properly. So we've laid that out. We've also included in there duties that we think of the Department of Health and Human Services, and things that they should do to try to help make the system better. And you've already heard about this rate setting and the gap in funding, which Doug could actually talk about, because it is in the report about the questions you had about the gap and how much we've lost and where we need to be. We put in performance measures. We want adequate staffing to help improve the application process, and make the application process more streamlined and more user-friendly. And I mean, some people wait months, or we just had someone, actually just yesterday, I learned of someone that it took them a 1.5 years to be approved for CFI, because all the complicated look back period documents and so forth. And so that, I mean, that might be an extreme example, but it's not unusual at all for people to wait months and months and months for these things to be processed. So there's that. We also want more transparency. We want to know, like, how are these rates being, well, I mean, there has been no rate setting. Let's just put it that way. There's been no rate setting for the last 10 plus whatever years. So, I mean, once rate setting starts, we want to know how it actually has been done, because it's not a transparent process at all. We want things posted, hopefully online, so we can see things. And then talking about, you just heard about not inadequate resources. We want a website that shows like what services are available so that people can access, like this agency is available to do this kind of service and so forth, because right now there really isn't a one-stop shop kind of thing to know what's actually available for people. It's very difficult to figure that out. So there's that. There's also the expansion of Service Link, as you heard about, to help them increase their capacity to provide long-term care counseling, and also to help people in nursing homes transition to the community. That's a new role we've proposed. It doesn't have to be through ServiceLink, but that's where we just placed it for now. The staffing, it is in the bill. We did include in the bill 5 new staff positions for the Office of Long-Term Care Ombudsman, and that you heard about the cost for that, which I think the ombudsman, the long-term care ombudsman, did help try to come up with some estimated numbers. And then also staffing for the department itself. So, which we're deferring to them to decide, like how many staff people do they need? We don't want to dictate to them how many staff people. So that's why that cost is undetermined, because we can't figure that out, and the department still needs to work on that. As far as the already existing statutes we want to amend, one was presumptive eligibility that you've heard about, and that's a process to allow for expedited processing of applications for home and community-based services. And it is important because unlike other Medicaid services, there is no retroactive coverage for this type of care. So it starts on the date that all the criteria is met to be eligible, both financial and clinical. And so people are basically just waiting with nothing, and there's no, they're not going to be able to get any retroactive coverage, so therefore nobody wants to help them, because if they don't have the money to, this is the dilemma. You've got to spend down to be eligible for Medicaid, and then you have no money, and then you've got to wait months to be approved. So that's a problem for this particular program. So we'd like to, presumptive eligibility has been in place since 2008. It's never really been fully implemented in any meaningful way, and it's been suspended the last 2 bienniums. So we haven't been doing it at all. There in theory could be a cost attached to it, but really in the end, there's studies that show in the end it ends up saving the state money. There's very little, the only risk is if someone is found, that's found presumptively eligible, might in the end not be eligible. So there might be this cost, but it's almost rarely even happens in that scenario. But
No.
okay, I'm almost through. Okay, so and then and then as far as yes, we also just added some pieces under 151E16 about cost estimates, again to have the rates be aligned with the CMS Market Basket Index, and then a new section about increasing the resource limit for home and community-based services for an individual from $2,500 to $15,000, and then also reverting back to, it used to be when a married couple applied, the person that was applying, they only counted their assets and income to be eligible, and not the spouses. And because of the Affordable Care Act, it had a change to mirror how they do it for nursing homes. I don't want to get all in the weeds, but the bottom line is it's a much more streamlined way to do it the way it was done previously. It's much less administrative burden. It would get rid of that long wait for all the documents that people need to provide. And I think I don't want to speak for the department, but my understanding was I don't think they oppose that, but I could be, they can talk about that. And then the last section was just generally amending the Office of Long-Term Care statute in 161F, just to be consistent, because we have asked what we're asking the Ombudsman's office to do is to expand their investigatory power to also include people on the getting home and community-based services, because right now there's so what they do is they just investigate problems for people in facilities and not home and community-based care. And there's other other waiver programs such as the DD program and so forth. They have protections in place for the participants. So, like, they have a Human Rights Commission they can file complaints with. There's nothing similar for CFI participants right now. So there's really there's really nowhere for them to go. So that's why we wanted to increase that role and broaden that role for them. So I will stop there because I probably gone on too long. But anyway, in the end, we really hope that you will vote ought to pass on this bill, and I'm happy to answer any questions if you have any.
Senator Avon?
Thank you, Madam Chair, and thank you for your testimony. You did a
You're
good
welcome.
job.
Oh, thank you.
Yeah.
Okay.
I just on the presumptive eligibility, my question really is just, why was it suspended and for how long? And if you want to go back to retro, how far back do you go?
Well, under Medicaid law, you can go back 90 days.
90 days, yeah.
Yes.
Okay. And why was it suspended?
You can, the department asked to suspend it, so I guess you can ask them. I think it had to do with, there was money placed in the budget, which I don't think that, that in the past had ever been done. And so I think the bottom line is that there was, that the legislature didn't want the money and it to be spent, and so they said, well, we need to suspend it. I think that's what happened.
Follow up? So you say the legislature or the department suspended it?
Well, no, the legislature ultimately suspended it because it's suspended by, the statute is suspended. It's a statute.
Would have been an HB2.
Yeah,
Oh.
HB2. Sorry, thank you.
But requested by the department.
Yes, that's my understanding, yes.
That's okay, you don't have to.
Yeah. We
Thank you
certainly
very-
didn't request.
And one final follow-up, if I may,
Follow
Madam
up?
Chair. And so by suspending that, what are the effects?
Well, it's people are waiting a long time to get found eligible.
Numbers, I mean, how many people are we talking about?
That, I could try to get that number for you. I don't know that off the top of my head, but I think a lot. I mean, because it's basic, I think a lot of the people that apply really meet the criteria. Basically what it is they have to have, have a certain income level that's low and no resources and no, obvious resources like big houses or, like rental homes and other assets, or trusts. If they don't have things like that, it sets forth what the criteria is for someone to be presumptively eligible. And I think a lot of the people fall in that category. And so therefore, they have to go through the full process instead.
May I have one more?
One last question.
One last question. Hairy eyeball. So this bill would basically do what with the presumptive?
We've actually, so there was, like I said, there was already an existing statute. What we did is we proposed new language because actually the language in the old bill gave the department 25 days to make a decision, which we thought was too long. And actually the CMS has said that's too long. They my understanding, told the department that wouldn't even fly. So we reduced it to 14 days. Yeah, that was one of the biggest, I think, changes.
Thank you.
Oh, you're welcome.
Any other questions from the committee? Seeing none?
Okay.
Thank you.
Thank you very much. And I do have some written testimony.
Thank you. Mark LaCroix?
Good morning, Madam Chair. Thank you for allowing me to testify in favor of SB 36. My name is Mark LaCroix. I live in Concord. I grew up in Berlin, and I have a clinical degree as a physical therapist. And I'd like to thank Senator Gannon and all the sponsors for bringing this bill forward, as I've been waiting a long time to tell this story. So when my father was 91, and he was living independently in a condo up in Berlin, he developed shortness of breath that made walking up the stairs to his second floor condo very difficult. Now, my dad at 91 was very active socially. He'd go out to Mass every morning. He would go to the senior center in Berlin for lunch and for fellowship. He loved making puzzles. And in the evening, he would do cribbage tournaments and or would visit with friends. And I say this so you understand that he was going up and down those stairs several times a day. It wasn't just like a once a day or once a week type of thing. And his shortness of breath got to the point where he began to isolate himself because it was too hard for him to go in and out. And I was very concerned about this. And I was worried, I was like, you may have to go to the nursing home if you can't maneuver the stairs up and down. So we made an appointment with his pulmonologist and we talked and he says, is there anything we can do to get him better, or is this going to get worse, or what's going to happen? And it was going to be a slow progression, and the pulmonologist and we thought that a stair lift would be helpful to go up his stairs. So I emailed ServiceLink in Concord to see if they had any resources to help him with his stair lift. And it took 2 months for them to get back to me to say no. And I had also asked if they knew of any vendor who serviced up in Berlin, because as you know, it's very rural up there and it's hard to get people to go up there for such a specialty thing. So by the time that had happened, my sister and I had decided we were going to pay for the stair lift ourselves, and we paid the $5,000 for the stair lift. And I found the company and it was installed. So by the time ServiceLink came back to me, I already had it installed and my father was back doing his normal activities in his normal life and going up and down and doing this. And this really allowed him to spend the next 2 years of his life in his condo. And he was living independently up there in his condo. And, I just say if he wouldn't have been able to go up there, and I had offered him to come live with me, but he goes, what am I going to do down there? All my friends are up here. I'm not going down there. So he stayed up there, and he wanted to be up there. And he says, if I have to go to nursing home, I'm going to nursing home up here. My friends are going to come visit me. I'll have fun up here. So he would have gone into a nursing home. He would have had a couple months worth of private pay, and then he would have gone to Medicaid. And for 2 years at a nursing home on Medicaid, it would have cost the state hundreds of thousands of dollars on that program. And, you get 2, 3 examples of him. I heard a figure, I think, from the first person, like 330,000 or something. 2 or 3 people like him, it would have more than covered that $30,000 in savings for the state for a $5,000 investment. So, I hear all these agencies talk about the technical aspects of this. I'm really here to be the face as to what this really means for that individual and for the quality of life of that individual. So I'm really hoping that you support SB 36. Thank you.
Thank you, Mr. LaCroix. Any questions from the committee? Seeing none, thank you.
Thank you.
Jill Martin. Oh, okay, sorry. Polly Campion?
If we ask Doug McNutt to go before me, I think he's just.
Sure.
He can speak to some of what I'll be covering.
Sure, 2 for 1.
Thank you. Sure.
Thank you, Chair Birdsell and members of the committee. I apologize for my raspy voice. I assure you I am not sick in any way that endangers any of you. So just get that off at the beginning. My name is Doug McNutt. I'm currently on the State Commission on Aging. I spent about 15 years working at AARP as their advocacy director. I spent the prior 15 years working for the Department of Health and Human Services, and I ended up being the Director of Elderly and Adult Services back when it was still a division. I have some written testimony here, but I'm going to try, which I'll submit, but I want to talk about several issues that I think are critical. One is that when we talk about the eligibility process, the difficulty is that the median length of time is 45 days. That means half the people go more quickly and half go longer. And it can be significantly longer. If a person cannot supply a particular piece of information, their application can be paused or closed, which can create months and months of additional time. I worked on this report from the New Hampshire Fiscal Policy Institute, and there are other parts of this that I want to address, but as part of that, I talked to a a hospital discharge planner who said to me, I deal with this application process every day, and yet there are times when even I can't make sure that I have the right documents at the right time. So imagine if you're not a professional, if you're a family member, how are you going to be able to manage that process? And that is why fundamentally the presumptive eligibility is so important. If you go to a nursing home and apply day one, and it takes, let's say it takes 2 or 3 months for you to get Medicaid eligibility, the nursing home will ultimately get paid for those 2 to 3 months. It'll happen down the road. But no home care agency is in a position to take anybody and wait for eligibility. They just can't do it. And that is the point of trying to do the presumptive eligibility. Now, there's been a lot of talk about how we're going to save money, and I want to be a little bit careful about that. I want to quote the immortal words of former Representative Neil Kirk, who said, it's actually about spending less, more money. And that's really what we're talking about here. I wouldn't come to you today and say, you're going to spend less money in 5 years. But think about the fact that you've got an aging population, thinking about the fact there'll be more people on the programs. If you can spend less, more money, you will be further ahead. And that is really the point of this. There is a chart in here, and I believe somebody else has it, copies of it, or if not, I'll give it to you. This is a chart that was in the New Hampshire Fiscal Policy Institute report. And that orange spot, that's the gap between what was funded under CFI and what would have been funded if we had been adjusted according to the CMS market basket, which is a home care measure that we're suggesting be used. And so I just visually, you can see it's 100 and, oh God. It's over $100 million, and it's $153 million over from 2011 to 2021. And so that's the depth of the problem that we're in right now. I think it's critical that we move forward on that. I know the other thing I would say in terms of cost is the department and their budgetary request and their prioritized needs have asked for additional funding for the Choices for Independence program, or CFI, and we would support that budget request because we think that that's important. And I just want to remind you in terms of the less money over time, you know, I'm a baby boomer, and as is apparently Senator Gannon. I remember that we built schools for people to go to school in, and when the baby boomers washed through the system, we didn't need those slots. The same issue would happen to us if we were decided to build more nursing homes today. Really, in 15 or 20 years, we probably wouldn't need them. So to the extent that we can control the number of people that need to go into nursing homes, and there will be people that need to go into nursing homes, there's no doubt, but we need to limit that number as much as possible because it's what people want, and it's also will help us maintain the fact that we don't need to build more facilities, which I think would be really in our long-term interest. So that's what I would say about that. The cost, I've submitted testimony that talks about the difference in cost between nursing homes and home care, and I admit that not everyone can be taken care of at home, that's for sure, but I think many people can, and if we have better supports and more options for people, I think we can do better. So I would leave it at that. I'd be happy to answer any questions about any part of the bill that you would like, or about this report.
Senator Bradley.
Yes, thank you, Doug. So referring to this chart,
Yep.
and back to your written testimony, if I understand it correctly, the changes that were made in the 21 budget increased the state budget appropriation from about 55 to $72 million. But the market-based gap is that difference between 72 and 97. Is that correct?
I think so. I think that's right, Senator. And just to be clear, there were really only a handful of services that got a significant increase, and that was good. There was a very significant increase in adult medical daycare and personal care services. So those items got a significant increase. I believe the rest of CFI got about a 5% increase. So I think that, you know, there's a discrepancy there, but yes.
Right. I know that the department is about to testify, so I can follow up with my questions with the department. Thank you.
Any other questions from the committee? Seeing none, thank you. We have three more speakers, and then the department will come up. And just keep in mind, we have two more bills we have to hear after this, so. Holly?
thank you for allowing me to defer. And if it's okay with you, I'm going to invite Rebecca Sky up with me, who's the Executive Director of the Commission on Aging. So if she's one of the other speakers, you can take her off your list. So good morning, Chair Birdsall and members of the committee. My name is Polly Campion, and I am a retired registered nurse and the immediate past chair of the State Commission on Aging and a former legislator. And I'm here in my role as it relates to the Commission on Aging. And I will shorten my testimony. I think Rebecca has a handout of our the executive summary of our annual report, which will address a lot of the issues. But what I'd like to start off with is answering in one way one of the questions that Senator Whitley asked, which is, why has this happened? And I think it's obvious to everybody in this room that as we age, we become less visible. Older adults fade into the background in terms of obvious activity in society. That is not true across the board, and many of us as we age continue to contribute great things. But the way of valuing older adults is such that needs as we age are not present. We as baby boomers tend not to stomp our feet and demand services. That may change as some Gen Z or millennials age. It'll be interesting to see. So just from a cultural perspective, I think that is potentially one of the reasons that we are where we are. You concerned about that? No.
I think we have another crisis.
Yeah, well, just barely. I think culturally younger adults tend to speak up for themselves more, is what I'm saying, than those of us as we're getting older. The Commission on Aging, or the establishment of the commission, recognizes that we live in a demographically aging state that could benefit from forward-thinking public policy and initiatives that ensure that we all have the opportunity to thrive as we age, and rather than become invisible. Over the past 2 years, the Commission has been deeply engaged in learning about our current systems of care for older adults. And 5 things have become abundantly clear. And you've heard most of these referenced, but just to be very specific about them. First, most older adults would choose to age in their community, preferably in their own home, if asked. Secondly, most of us do not plan ahead, but rather respond to a crisis. For instance, after a fall or some health crisis has occurred and we recognize we need more care than we currently have. Thirdly, and you've heard references to this, a crazy quilt of services exists that provide support to older adults in need of home and community-based services. Fourthly, the information and options counseling is difficult to find. And I am concerned about those who seek to answer questions when services are needed, because they just aren't available to the extent that they're needed. And lastly, agencies, as you have heard, are understaffed and underfunded. And one point about the understaffing and underfunding, one of the things that we have recognized is that I think in 2021, it was 32% of all direct care providers, direct care staff who work on home and community-based services and in nursing homes and others, receive one or more types of public assistance. SNAP, public assistance in cash or on Medicaid. So we are paying, not in terms of salary, but we are paying in terms of other supports. You've heard from Doug McNutt about the study that he and Phil Sletton produced from the Fiscal Policy Institute, and they presented their report to the Commission. In addition to presentations to the full Commission, one of the task forces that exists is specifically focused and has done a deep dive on aging in communities of choice. And that's where much of this information has arrived. And just to reference Senator Gannon's comment that the commission meets 6 times a month, many of those meetings are task forces, not the full commission. One of our strategic objectives is to develop and advance strategies to improve people's ability to age in the communities of their choice. And were this bill to be implemented, it would represent great progress in closing those gaps while not filling all of the needs, again, as you have heard. Rebecca has distributed the executive summary of our report, and I'd like to point out just a couple of things from that document, if you will bear with me. First, look on the back side of the last page. So it looks like this, and you'll see lines that indicate various aging groups over time. And you will note that the growth of the 85 plus population through 2050, the New Hampshire Office of Strategic Initiatives projects that the 85 plus population in New Hampshire in 2050 will be almost 70% of our state's total population. So the 85 plus are called the old, and they're the people who will potentially need nursing home care, but we've heard several anecdotes today about 90 plus people who are continuing to age in their home.
So 7%.
7, did I say 70? Oh, wow, that would be shocking. Thank you.
That would be shocking.
Thank you. That's why Rebecca's here. And that growth is why we need to address our system of care, in addition to all of the younger old groups. And if you turn to the first page of the report, you will see that the commission has 3 broad recommendations for the governor and you as legislators. And our mission as a commission is to provide recommendations about public policy to you and the governor. The first of those priorities is to strengthen our long-term services and support system of care. The commission has been involved in the development of this legislation, and at our monthly meeting last Monday, we voted unanimously with 1 abstention from the department, which was appropriate, to endorse this bill conceptually. And we recognize that there are likely to be amendments and revisions to make it even better, but we ask for your support for this bill and to help it move forward. And are here to answer any questions. And Rebecca also has some specifics that she might want to share.
Go ahead. I just wanted to add 2 points. So my name is Rebecca Sky. I'm the Executive Director of the State Commission on Aging. One, just to clarify, I think that everybody around this table understands this, but with the idea behind presumptive eligibility is to create a mechanism in the financing in the way that CFI is financed, to put it on par with what's done with the Medicaid nursing facility program. In that, with the nursing facility program, they are able to get that retroactive payment, which is what allows hospitals to discharge directly into nursing facilities, and why there's such a pipeline that goes that way. And without such a similar mechanism in place for CFI, it's just a service that gets bypassed. And you know, as been said, we need our nursing facilities. It's the right placement for some people, but for some people, they don't need that 24/7 care, and it would be more appropriate for them to be in their homes. And that is more cost effective for the state. And so that the presumptive eligibility would allow that to happen so that hospitals can more easily discharge people to home-based care. And then just to follow up on the presumptive eligibility, Polly mentioned our task force. We do have a task force meeting February 13th that is going to do a deep dive into presumptive eligibility. We're going to learn from some experts, national experts, about other states' experiences with it, to really understand how it's not the risk that is initially perceived with it. So you're welcome to join that task force. It's open to the public, but we will certainly share our findings with you.
Thank you. Any questions from the committee? Seeing none, thank you.
Thank you for your attention.
Okay, we're down to 3. Christina Fitzpatrick? Okay. Carolyn Virtue? Welcome.
Good morning, Senators. Thank you for this opportunity to speak with you today. I'm not going to read through my testimony, but I would like to comment on a few things here. There are 2 things being discussed here and they are very separate and distinct. And I'm very concerned that they are being melded together to the detriment to one or both of those programs. Long-term care systems and systems for healthy aging are very different. This bill adds a system for healthy aging to New Hampshire's long-term care statute. Our long-term care statute is intended to serve people with needs. I see every day the horrors that have been described to you today. So I will not reiterate on those, but I beg you not to take our healthy population over 60 and our able-bodied citizens and add them to that system that is, as you have heard, already overburdened. So I have no problem whatsoever with addressing the needs of the CFI waiver, and they are great. But I think it would be foolhardy to add our healthy elders over 60. In my handouts to the committee, I have our brand new census information. This bill, adds 269,000 people at a minimum because the census doesn't report on our citizens over 60. It only reports on our citizens over 65. And that is the other thing that I would find concerning is moving the age for older down to 60 and not up from 65. Because many of us are working, participating members of society well beyond that now. The service link, I thought of this sitting here, it's not in my testimony. I remember like it was yesterday when the department came to you and said, we need the service link. I think it was during a budget hearing, not a Health and Human Services Committee hearing. And there were questions about, well, who's going to pay for this when the money runs out? This was, I think, 20 years ago or more now. But and the answer was they would become self-funding. Well, clearly, they're not self-funding. And the service link is not currently codified in statute. And I don't understand why it's a good idea to do so now. My other concern with the service link language, although the bill leaves out the words case management, the transitional services that they are talking about here are case management, and we have a statute, a current statute that says those services should be provided by independent case management companies. So the service link language is not consistent with that. The other, and I have the statute listed in my comments. I'm trying to be brief in the interest of time. The other thing about the service link language is other providers of similar services have popped up. So you can go on to say New Hampshire Navigator or the Foundation for Healthy Communities, I believe. So the service link is not the only game in town. Others have stepped up to do insurance and other navigation. So I would ask you, why would you make it singularly a service link game with this bill. Actually, I'd ask you not to let the market prevail. I have a lot of concerns. The first time I read the bill was on Friday, so there are a lot of words here to get through, but words mean things. In closing, I would ask that if you do create a new system for healthy aging, that you put it in its own chapter, not our long-term care statute. And I ask that because we already don't have enough money in our long-term care statute. And I think if we take the care for healthy aging people and put it in here, the money is going to come from CFI or nursing home lines. If you wouldn't put it in a new statute, I would ask that at the very least, you safeguard the lines of CFI and nursing homes from the money being spent on the healthy elderly. And again, I am not opposed to helping the healthy elderly. But there's a cost to that, and I don't think that's figured out here in this bill. The other thing that I would ask is, by creating that new category of eligibility by virtue of age and one ADL, the current statute is 2, so you're reducing that. What if, and I believe it will be true, those people who were made eligible by virtue of their age have to be added on to the MCO rolls, the over 60 population, by making them eligible as they are here. And if that is true, and I am saying if, I'm asking you to look at it. So I read a lot on the CMS website, and I'm pretty sure if you create an eligibility category, you can't limit the eligibility. So if you were to add those over 60 people to the MCOs, assuming they could go into the lowest cost category, and I'm not sure that they could, of $435.25 per person per month, the expenditure that you're talking about here is $117,203,938. So I would say that more study is required.
Thank you so much for your testimony. Any questions from the committee? Seeing none, thank you.
Thank you very much. And as always, it was.
Did you say you had written testimony?
I have that. So everything I said, Senator, and more is right there.
Thank you.
I was, when I wasn't joking that I was being brief. I was being brief. And I'm happy to discuss anything that's in my written testimony. Anyone can call me at any time at 603-848-7345.
Thank you.
Thank you.
Okay, we are down to the last two. I am going to bring up DHHS right now. We have one speaker after that, and I just want to remind people, we have 2 bills after this to go over. So DHHS, come on up. Melissa Hardy and Wendy Altman. Oh, here. Welcome.
Good morning. Still morning.
So far.
Do you want us to introduce ourselves for the record? Okay. Thank you. My name is Wendy Altman, and I am the Bureau Chief for the Bureau of Elderly and Adult Services at the Department of Health and Human Services.
Good morning. I am Melissa Hardy. I'm the Division Director of Long-Term Supports and Services at DHHS.
So my understanding is that, and we've been working with our colleagues within the department to put forward a fiscal impact. We understand that that will be in front of the LOB within the day. Any follow-up questions that come, after the review of that, we're happy to answer. I'll just give a brief introduction to myself in terms of my role and the Bureau's role. And I've been with the department for 24 years. Many of those years have been spent working in different roles within the Bureau of Elderly and Adult Services. So I'm happy to provide any information or answer questions and also address any of the things that came up during testimony today as a representative. I also sit on the Commission on Aging as the department's representative. Over the last several years, I've been partnering both with the commission members as well as the New Hampshire Alliance for Healthy Aging on any systems change, improvements, and working with them to answer any questions and provide guidance relative to the Bureau and their role. In addition to the CFI program, the Bureau of Elderly and Adult Services oversees the Adult Protective Services program, as well as administers all of the Older Americans Act services for individuals 60 and older, like home delivered meals and in-home care, to serve those people who aren't eligible for Medicaid. In addition to that, we receive social service block grant funding on general funds, and we also serve adults with disabilities and chronic illness who are 18 and older.
Thank you. Again, Melissa Hardy. I am fairly new to the department, about a year in, so this is my first round, so thank you for having us. I just want to echo what Wendy says. Our fiscal impact should be done either by the end of today or by tomorrow, so we will get that out as soon as it's completed. And happy to answer any questions.
Any questions from the committee? Senator Whitley.
Thank you, Madam Chair, and thank you for taking my question. We heard a fair amount of testimony about how, the system has been sort of degrading over the past decade. And I'm wondering specifically if you could share, the department's thinking about, not requesting that funding for presumptive eligibility and really not looking at those rate increases. What are we missing here?
So yes, over the last couple of hours, I've heard, and I made some notes about some of the questions, what brought us here today, and why is our system seeing the impact that it is. So I would just speak to, first, the presumptive eligibility. We did request some funding. It does take general funds, unless we have approval from our federal partners at CMS to allow for covering services that are also covered under CFI prior to them being determined eligible for a home and community-based services waiver. So we have to either seek CMS approval in order to operationalize something that could be covered and receive federal match, or we would need 100% general funds to cover that.
And so did the department pursue that, or I'm just trying to sort of figure out where the gaps were.
We have not explored looking into applying for a what's called an 1115 waiver with CMS to cover presumptive eligibility. We know that some states have done that in order to cover a program such as that. But we did, I believe it was the biennium before this past one, requested general funds to cover that, and we did not get those funds.
So, two quick questions. I'm assuming in your budget request to the governor, which obviously we haven't seen yet, you are requesting a rate increase for CFI.
Yes, part of the prioritized needs is looking at the increase. I believe we ran the numbers to look at a 3% increase based on what
And
we
so
had.
the fiscal note will reflect what you're asking for in the budget.
I believe that there is mention to the prioritized needs request in there.
Okay. And will the fiscal note separate between CFI and healthy aging?
The fiscal note addresses the different parts and sections of the legislation as they're written. Certainly, some of the comments and testimony that have been provided today can be discussed and taken back, but we addressed them based on how the legislation was written.
All right, so I'd request that.
My understanding also is that based on the review of the language in the bill, we're not looking to expand the CFI eligibility to others who would not necessarily meet the eligibility criteria currently for CFI. And also within our Bureau of Elderly and Adult Services, I'll say this to anybody who will listen, aging, everybody's doing it. So, the conversations that we have with individuals across the state, whether that's while we're currently working on our state plan on aging or publicly funded programs that we administer, as we said, CFI serves individuals 18 and older with chronic illness or disabilities, as well as those who are older. And in terms of looking at those who may be aging, and the testimony that was provided to talk about how people may plan or look to explore what their options may be before they have a crisis. During the testimony, it was mentioned that, ServiceLink, which is our Aging and Disability Resource Center designation for the state, it's a program that every state has in terms of aging and disability resource centers. We designate our ServiceLink contractors to do that work. And we look to that program to really address helping to do the outreach and education and the planning prior to more costly care being needed. And we do that also through several of the other programs that are provided at ServiceLink under one roof, which is the Medicare counseling, caregiver support through our Older Americans Act Family Caregiver Program, as well as our long-term support options counseling, which is available to people whether they qualify for a public program or not, which really looks to provide equity amongst those who really want to talk about planning for aging and may have some resources to pay for that, and want to plan so they don't have to spend down their money and become eligible for Medicaid. But if they do, they're there to, the purpose really for them also in their contracts really is to help them through that process.
Senator Avard.
Thank you, Madam Chair. We have heard testimony about for application for CFI approval to the extreme of 1.5 years, 1.5 years before this applicant was able to be eligible. Does this bill fix that with the 3% increase proposed? And what would cause that delay?
Sure. Well, I can speak to our vision would be that I hope that there can be assistance in streamlining that process. I think several areas within this bill, whether it's presumptive eligibility or having more people to help somebody through that process, will help in terms of the preparation and information that's needed in order to have a successful application for Medicaid. I think in my experience, 1.5 years is an outlier. But there, in some circumstances, there can be resources, transfers of assets and property that can delay or, in some instances, penalize somebody to spend down their money before they actually become eligible. So, in perception, in terms of filing an application and when they actually become eligible, in those instances where those things are happening, it can take some time before they actually become eligible.
And a follow-up, if I may? Yeah, in regards to case management, we heard in testimony that they're supposed to be independent. How does this affect independent case management organizations?
Yeah, so I think that's a really good question. And as I was reading through the bill, the provision of Medicaid case management or case management in general didn't necessarily cross my mind. It was mentioned that it was not written in terms of that actual language being in there, but certainly the role of case management for those who have access to that through Medicaid or through the Choices for Independence waiver program certainly is part of the system of access for those who are eligible, and we want to have them stay eligible. But the role that ServiceLink has in this process, in most cases, typically we're engaging with people either prior to their eligibility or as they become eligible, supporting them with information and guidance and services that supplement or augment what CFI covers.
Thank you, Madam Chair. And with regards to ServiceLinks, are there other organizations that does what ServiceLinks does, and we're only talking about ServiceLink? Can you elaborate a little bit why?
Yeah, so we get this question often as it relates to agencies and services like 211, or as was mentioned in testimony, navigation programs. The department does work with some navigation programs to assist with phone and telephonic counseling or support for individuals who are looking to redetermine their Medicaid or become eligible for Medicaid. And not necessarily the bulk of their work isn't necessarily with long-term care, but helping individuals to ensure their eligibility. The role and purpose that we have for ServiceLink that's in part one of the ways in which ServiceLink can help, but it's not the only support or service or funding support that we have within their contract. So they do in-person support. I think this bill proposes additional resources which would allow them for us to require for them to do home-based visits and have the resources to be able to do that. I believe that the language in this bill will help support. That's one of those differences between, those navigation programs that are focused on typically one area. And that's just one example. The navigation program that the Bureau of Family Assistance uses really is focused on the Medicaid aspect or through public programs that you can apply for through the
Final
department.
question. And my final question, thank you, Madam Chair, and I apologize, but you know, people do get concerned about government over bloating, and one of the questions, one of the problems was dropping the age down to 60 for healthy individuals, and that was a concern for one of the testimonies. And I think there was a price tag of $100 million that, or thereabouts, that was mentioned within that discussion. Is it necessary to drop it to age 60 for healthy individuals being included into this program?
I did not interpret the language to make that impact. I don't understand. I would have to have some more discussion to understand the statement that was made, because I did not read the bill to, and then I didn't interpret the bill to say that.
Thank you very much.
Senator Whitley. Oh. Okay. Any other questions from the committee? Seeing none, thank you.
Thank you.
And we have our last speaker. And again, everyone, we have 2 bills after this. Alex Kutrobis.
I know you have to go. I know the chairman of finance has been in the lobby for a long time, so I'll be 3 minutes max. Thank you very much, Madam Chair and members of the committee. My name is Alex Katrubis. I work with several provider groups that could be impacted by this legislation. I just want to talk quick. First group, New Hampshire Healthcare Association, who represents the private nursing homes in the state. Brendan Williams, who's their CEO and president, sent you a letter, which hopefully you've received. This bill does not directly impact nursing homes in the state. However, it is, as you've heard, about healthy aging and seniors in New Hampshire, so we feel it's important to weigh in. The nursing homes are generally supportive of the aims of Senate Bill 36 without getting into all the facets of this very comprehensive bill. And that's really because nursing homes do support home and community-based care. However, we will want to point out just a couple of things that should be understood. If you look at other states, and again, this is discussed in Brendan's letter to you, other states that have grown their home and community-based care systems have not shrank their nursing home caseloads. They have seen exponential increases in home and community-based care demand that may not have otherwise been accommodated. They have not robbed Peter to pay Paul. And right now, I think it's important for you to understand that nursing homes in New Hampshire are hanging on by a thread right now. They are being financially squeezed by temporary nursing staff agencies. They have very large numbers of in-house staff vacancies. They're dealing with major cost increases in food and energy. And I gave you a packet of letters that several nursing homes from around the state sent the Department of Health and Human Services this fall. You can see the Hillsborough County Nursing Home. They have 73 vacant nursing positions. They have 108 total vacant positions. Maplewood Nursing Home, they have 67% LNA vacancies. St. Joseph's residents, they have 6 nursing positions open. They're spending over $15,000 a month on staffing agencies, even after significant wage increases to their own staff. Their food costs are up 10% versus last year. New Hampshire Catholic Charities right now, it has a $285,000 loss on their fiscal year. They're spending $77,000 a month on staffing agencies, even after increasing their own in-house staff. St. Vincent has a wait list of 8 prospective residents. They have a monthly loss of $30,000. They're spending $160,000 on staffing agencies. And lastly, Golden View, they have a low occupancy rate of 70%. They have 15 full-time nursing positions open. They're spending $63,000 a month on staffing agencies, despite attempts to recruit and retain their own staff. Their food costs are up 25% compared to last year, and their energy costs are up more than that. So the point is we need to support home and community-based care, and the nursing homes support that, but we also need to invest in skilled nursing facilities that provide a wide range of health and personal care services. So we're recommending some minor changes to the statement of purpose. It's all outlined in Brendan's letter. I know you have to move on here, so I'll just leave it at that. I also represent Meals on Wheels New Hampshire. Hopefully you all have the spreadsheet. That is the fiscal year ending 2022, June 30th, 2022. The nursing, I mean, excuse me, the Meals on Wheels providers, the 10 home delivered agencies from around the state, they strongly support this bill. They support the efforts to require the department to better recommend rates for CFI that reflect the true cost of the services that are provided. They also support the sections on ServiceLink. You can see that last fiscal year, we distributed 1.8 million meals to 15,852 people. Not all of that is Medicaid. As you probably heard a lot of times this morning, CFI is a home delivered. It's not congregate. It's not grab and go. It is a home delivered benefit. The current rate of pay for that is $8.11. That's what the providers get. That's not what the meal costs. It's a 50-50 match, as you know. I was speaking to the Stratford County program yesterday. They tell me that CFI home delivered meals is about 16% of their population of home delivered clients, and it plays about a 22% of their revenues coming into their agency. So the last thing I'll say is I just want to applaud the groups that put all the effort into this bill. They reached out to me and asked for my input and support, which is, I think, is a good way to conduct legislation. And I applaud their efforts putting this coalition together. And nursing homes and the Meals on Wheels providers support it with some caveats. So I apologize. I know I said I'd be quick, so hopefully that's okay. We can get to Senator Gray's bill. Thank you all very much.
Alex, thank you for the very pithy update.
You're welcome. I could go on. I could talk about DD if you want, but I know you got to get to lunch and 2 more bills. So
Any
you'll
questions
see me
from the
more.
committee?
Thanks a
Seeing
lot.
none.
Appreciate
Thank
it.
you.
Thank you, Senators.
With that, I am going to close the Senate hearing on Senate Bill 36 and give Cam a little time to organize, and we'll go on to Senate Bill 34. I apologize for making the Chair of Finance wait so long. With that, we'll open the hearing on Senate Bill 34, relative to controlled drug prescription health and safety program. And welcome, Senator Gray.
Thank you, Madam Chair. For the record, my name is James Gray. I'm the senator representing District 6, which starts in Belknap County and goes down in Stratford County. Today, I'm here to introduce a housekeeping bill, Senate Bill 34FN. In July of 2021, we did some transferring from the Office of Personnel Professional Licensure to the department. We made a couple of errors in there we need to correct. Right now, the bill talks about, or I should say the RSA talks about program administrator. That'll be changed to commissioner. We corrected the Governor's Commission on Alcohol and Other Drugs. That's another clerical error in there. And we're moving two things. We're moving definition of chronic pain, and we're moving prescriber competency requirements back into the statute for OPLC, which is 318B colon 41. The biggest change is the last thing that you see on the sheet from me that you've got there, and that is allowing the department to release data down at the county level. Right now, the way it's structured, they can only release it at the state level, and there was also some talk about being able to do it the first 3 digits of the zip code, but that doesn't line up with the things that we need it to line up with. Doing it by county will help greatly, and right now it would be prohibited. So if you have questions, I'd be glad to try, but there's people in the department that are just waiting to get up here so they can get to lunch too. So.
Any questions from the committee? Seeing none? Thank you. Michael Holt from DHHS, welcome.
Thank you very much. For the record, my name is Michael Holt. I am a section administrator that is responsible for the oversight of the prescription drug monitoring program within the Division of Public Health Services. I want to thank Senator Gray for introducing the legislation. He stole most of my thunder. This is department requested legislation. So as such, we support the passage of this bill. As Senator Gray said, the PDMP, as it's colloquially called, was transferred from OPLC to HHS via House Bill 2 in 2021. And since then, a number of technical issues have been identified that need remediation. This is a technical cleanup bill. Like Senator Gray said, the current RSA holds responsibility for the program administrator to do certain functions that may have been appropriate for when it was organized under the pharmacy board. But now that the program's organized under the commissioner, those references should, that authority should be given to the commissioner and not the program administrator, a particular staff person. There's a technical cleanup on the Governor's Commission on Alcohol and Other Drugs that has to do with membership on the PDMP Advisory Council. 2 sections of law need to be transferred back to OPLC regarding the definition of chronic pain and competency requirements for various healthcare providers. And as you said, lastly, the transfer this bill would allow and correct an unintentional error to allow the PDMP to release de-identified aggregate data at the county level. Historically, the PDMP had been able to release location data since its inception, including data at the county level. And when it was changed, transferred via House Bill 2, the confidentiality standard was changed. The new law invoked the safe harbor standard under HIPAA, which is the strictest data release standard within HIPAA. And what that means is that we can only release data at a statewide level with one exception. The exception being using the first 3 digits of the zip code. This doesn't align with county level data. So in the past, we were able to release data for Manchester only. We're not requesting that. We're requesting simply to go back to being allowed to release county level data. The last 2 notes I'll make is that we've worked with OPLC on this legislation. They have no objections to the 2 sections of law that are being transferred back. We also worked with the PDMP Advisory Council with a legislative subcommittee on this bill. And at the last PDMP Advisory Council meeting in December, the council voted in support of this legislation. I'm happy to take any questions. I encourage support of the bill as it's a technical.
Any questions from the committee?
Congratulations on your promotion.
Well, yeah, I was only running one program, so they figured give me a second program to run. Everybody else was running three, so
And you were doing a great job, so
Well,
congratulations.
thank you. Thank you very much. I do have testimony that I'd like to hand out, and as well as this, fancy color map that shows the ZIP 3 overlaid with the county data. Pictures, right. Any other questions?
Seeing none, thank you.
Thank you very much.
Anyone from the
What's that?
audience want to speak? Seeing none, I'm going to close the hearing on Senate Bill 34. Huh?
Great, thank you. Thank you very
We
much.
got one more.
There's like a hole in the middle of it.
All right, opening the hearing on Senate Bill 30 and relative to membership to the New Hampshire Council on Developmental Disabilities. Welcome, Senator Whitley.
Thank you, Madam Chair. Good afternoon, members of the committee. I will be brief. I know I am standing between you and your lunch. For the record, my name is Becky Whitley, and I'm honored to serve New Hampshire Senate District 15, which now includes the communities of Bow, Concord, Pennacook, and Hopkinton. So this is also a housekeeping bill. It was requested by the New Hampshire Council on Developmental Disabilities. If you don't know, the council is a federally funded state, but it's also a state agency. And that promotes the self-determination, integration, and inclusion for New Hampshire citizens with developmental disabilities. I was a former member of the council when I was a staff attorney at the Disability Rights Center, so I'm honored to bring this bill forward. So just really quickly, the council, because it's state funded, federally funded and set up through federal law, they have federal laws that they have to follow. So pursuant to that federal law, the council is made up of at least 60% people with developmental disabilities or their guardians. So the purpose of this bill is really a housekeeping to update the RSA in alignment with their other federal requirements. The council is required by federal law to set aside 9 seats for various state agencies and their federal partners. And the current wording of the council's membership states that they can have no more than 21 members, but changing that wording to at least 21 will bring into compliance with their federal mandate for all the other members that they are required to have under federal law. Alongside that change in terms of membership, the council is requesting removal of the language you'll see on line 23, because they feel that it's caused some confusion for council members who fill seats vacated midterm as to when their term ends. So I'm happy to take questions, but I know the council is here so they can defer any technical questions on their federal mandate, their federal statute to the DD Council. Thank you, and I ask for the committee's support of SB 30.
Any questions from the committee? Thank you, Senator Whitley. Vanessa, welcome.
Thank you. Thank you, Senator Whitley. Thank you, Madam Chair and members of the committee. My name is Vanessa Blaze. I'm the Director of Policy and Planning for the New Hampshire Council on Developmental Disabilities, and I'm here in support of the bill, and I'm also here to answer any questions that you might have about it.
Welcome and thank you.
Thank you.
Any questions from the committee? Seeing none, thank you. Oh, I'm sorry, Senator Bradley.
So it is federal law that requires, I think Senator Whitley said 16 members with developmental disabilities. Did I understand that correctly?
Our federal law requires 60% of our council be people with the lived experience of disability or their parent or guardian. So essentially, we say 2/3 of the council. Then we also have
And so since we require 9, that's where the 16 comes.
the federal requirements also include that we have to have 9 set aside seats
And these seats are specifically for state agencies, our DD partners, which are the DRC and the IOD, and also certain other organizations in the state.
All right,
To
so the
clarify
9
this,
triggers the 16, which is, okay, all right, thank you.
yes, so it's basic math.
Yeah.
Any other questions from the committee? All right, seeing none, thank you.
Great, thank you very much.
With that, I will close the hearing on Senate Bill 30. All in favor of exec, say aye.
Aye.
Opposed? All right, so why don't we go,
30, you want to do that one?
yeah, might as well do 30 first.
Move out to pass?
Second.
All right. Any discussion? All right, all those in favor of ought to pass, say aye.
Aye.
Opposed?
Consent.
Second?
All right, all those in favor of consent, say aye.
Aye.
Aye. Opposed? All right. Senator Whitley, you want to take this out?
Please. Thank you.
Move to 34, which is the other review.
Un momento.
I can count.
You don't want to make Marie.
No, no, I don't.
No, no, no.
I can do this.
32.
32?
32. The opioid abatement trust fund.
I move out to pass.
Were there some changes that they wanted to do?
That was on 35.
In
They
the
wanted.
beginning of the bill, they want a collaboration with the department.
Yeah, so on line 8, the commission shall, or the commission,
Yes.
we should say shall work to collaborate as to how many times the department
And strike the word sold.
sold. Oh, yeah.
Yeah, instead of sold, in collaboration with.
The commission shall work to collaborate, wait. Will work to collaborate as to how many times the department shall be collaborative. The
what I
commission,
Why don't we say it this way? The commission shall collaborate with the department as
There
to
you
how
go.
many times the department shall solicit. It's not good grammar, but it works.
So I'm going to read that back.
okay, thank you.
Line 8, beginning on line 7. The commission shall collaborate with the department as to how many times the department, and then it continues as.
Correct.
So Senator Bradley made that.
So
amendment? Moved it?
I amend my ought to pass motion to include. No,
Nope.
can't do that.
Nope, your ought to pass motion opened up the floor for an amendment.
Got it.
Senator Bradley just moved that amendment.
Got
So
it.
now Senator Bradley needs a second on that amendment.
Second.
Okay. All those in favor of the amended?
Aye.
Aye.
Aye. Opposed?
I did have a concern though about the nonprofits.
Well, from my understanding, it was only, well, you had a concern because of it, but it was only the reimbursement.
Right, but hospitals and
So let me
VAs.
ask, can I ask John a question?
Mhm.
If you have reimbursement to political subdivisions, okay, does that mean that currently now a community health center or a not-for-profit hospital could request direct reimbursement from the department, and that would no longer be the case?
That would be my understanding, Senator Bradley, and I think that would resolve your concerns. Other things that you could
So
consider is
currently, they're able to seek that reimbursement, hospitals or community health centers.
that is my understanding based upon the language that's currently in statute now. How the process works specifically, you'd have to consult with commission members to find out how in practice it works. I would note that if you notice that the subparagraph B1 is also followed by a set of other paragraphs, the header on that section actually identifies on line 22, reimburse the state and any political subdivisions. And then they talk about the breakdown of that. So I think the reason why they wanted to amend it by striking the other language was to make it very clear that this was dealing with the reimbursements to the state and political subdivisions, because that's what the specific section references in the very beginning of that subsection, if that makes any sense.
It does, but does that make the community health centers and the hospitals ineligible?
I would say to Senator Bradley's thoughts, I think it's helpful. I don't think I got the sense from the proponents for the bill that no one would have an exception or any issue if you were to include such language in it. If there was a concern or problem, they could certainly get back to you folks at a later date and time if you wanted to include hospitals as well in that statement. But I think the way that it's currently worded, that subsection, it is specific to states and political subdivisions.
Well, they didn't testify.
Yeah, I know.
That doesn't mean there's not an issue down the road. But what we could do, we could pass it out as is. It could go to finance and we could ask that question
Yeah,
in the intervening time.
okay. Are you guys,
But can I make a suggestion, Madam Chair?
Mm-hmm.
Would you, John, reach out to Paula Minahan of the Hospital Association and whoever is the, who represents the community health centers to see if there's an issue? And then when it comes to finance,
did Paula Minahan sign in on this? Can you?
I don't
I
think
should.
so.
Oh,
She was unaware of it. So I brought it to her attention.
okay.
And somebody mentioned VA as well, nonprofits. I don't know if that's part of the discussion, but.
I mean, the other thing, we could just sit on it.
Yeah, why don't we hold off on this till next week until we get some of these questions
Will you try to
answered?
find
So
those answers?
because
I
we-
will.
Because there was already a motion made and voted on, you would then have to vote to reconsider to reset the bill to being blank, because right now we have pending motions.
Can I just withdraw my motion?
Well, we've already voted on it.
Motion to reconsider?
I'll second that.
Okay. So we can, it
And what
doesn't-
happens?
It's not gonna hurt it, we're just gonna be able to discuss it.
Right.
Right. So the motion to reconsider.
Oh, okay. All right. All those in favor of reconsideration?
Aye.
Say
Aye.
All right. All opposed? Okay. All right. The RSV vaccine?
I'll move on to pass.
Any discussion?
I would just say, I think it makes sense in the future to allow pharmacists to administer all approved vaccines by the FDA. But before we do that, I think it should come in as a separate bill. We've had this bill in front of HHS numerous times to expand this for pharmacists to be able to do that. So I don't think it's that big a deal. Somebody can bring the bill in.
I'll bring it in next year.
Next time.
Next time. All right, where are we? Was it ought to pass and seconded?
Yep, so we have a motion of ought to pass made by Senator Bradley, seconded by Senator Prentice on Senate Bill 35.
Any other discussion? All those in favor say aye.
Aye.
Opposed?
I'll move consent.
Senator Bradley moves consent, Senator Prentice seconds. All those in favor say aye.
Aye.
Opposed? I'll take this out. Oh, actually, oh,
I was gonna say, I could take this out, but no, that wouldn't work very well. would it?
no, no.
You can't do that anymore.
Old
New
habits.
You can
gig.
get the next one. Relative, 34,
Move on to pass.
Second.
any discussion? All those in favor of ought to pass, say aye.
Aye.
Opposed?
Consent.
Second.
All those for consent, say aye.
Aye.
Opposed? Senator Prentice, you want to take this one out?
Absolutely.
Motion to move out of exec.
Second.
Motion.
All those in favor, say aye.
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 Aye. All right, we are,
Great job.
Good job, Madam Chair.
thank you.
Moving those bills.
Wish we could have got more out. We got three, not,